Doctors, we are live.
Okay, fine. Mukherjee sir.
Yeah, I'll start. I'll just share the screen first. Is it visible?
Yeah, visible sir.
Yeah, so let
No,
us
sir,
start.
screen share is not visible.
Screen share is not visible.
No.
No.
How can I go about it?
First have the PowerPoint on, minimize it and put it to one side, then start screen share. We just make it smaller rather than minimizing it and put it on one side of the screen.
Okay, let us start with this one.
And maybe we can start without the screen share.
I'll do that. Just 1 minute, I think I'll get it now.
I can share the screen. You just speak, sir.
Yes, you share the screen. Okay.
Visible, sir.
Yeah.
Yes,
Ready.
sir.
Make it full screen, please.
Okay. Okay, sir. The overall introduction. Welcome all. We have initiated this
Can
process.
you listen to me now?
Yes, sir.
Yes, sir.
So without the thing, Mehul will control this one.
Yeah. You tell me next.
First of all, I would like to welcome you all with the greetings from OTSI for the Diwali coming in just on the 14th of this month. And thinking of that, we thought that we should have something in this webinar to educate people and also us. So what we did, we thought that we'll have the video on this competition with the younger people who are actually given video to us, and there are about 53 videos came to us first. And what we did, we divided them into two groups. One is the anterior part of the eye, and other is the posterior part of the eye. And then we fixed few judges who evaluated all these videos. And finally, we came to a conclusion that there will be 12 videos will be presented, and those videos will be presented today. These are the incentive to the all younger ophthalmologists to show their work, what they are doing. Top of that, we thought that this is a good opportunity to hook in two very important persons to give us the keynote address, which is very relevant to the just before Diwali. One is Dr. Rupesh Agarwal. He doesn't need any introduction. He is Secretary of the Accord, and he has done a lot of work on trauma. Second is Dr. Mohan Rajan. He is more than half centurion in IPL leagues and other things. And it is a pleasure to listen to you, Mohan. And top of that, I thought that I should announce one more thing for the juniors, particularly for the younger generation, that those persons who will be the winner and the runners-up for this video competition, they will be invited as guests to the next physical OTSI conference. Whenever we are going to hold it, at that time they will be our guests. So those younger people will be joining us in our physical conferences. With this, I would like to hand over the whole proceeding to our dynamic secretary, Dr. Mehul Shah and Dr. Gover. Mehul, you can remove the screen share. Mehul, you can start with the proceeding.
We can start the proceedings. So, Dr. Grover, want to say something?
Just to say that it has been a wonderful exercise. This video competition has brought about a lot of interest in ophthalmologists across the country, especially the young people. And the quality of videos that I judged was excellent. It has really given us a new perspective into how much work in ocular trauma is going on. As Professor Mukherjee has discussed, this brings to the fore two things. One, that great role that we need to play in prevention, especially with the Diwali time coming, which is one of the major times when we get a lot of extra trauma. And second, the need for making the services more defined. As Rupesh has repeatedly pointed out, if we develop some kind of a coordinating person, some kind of a specialist in ocular trauma in each hospital who can coordinate between different specialties to streamline the services, we would do Indian ophthalmology a great service. So all major centers should start having an ocular trauma specialist who can coordinate the interspecialty functions so that we can improve the quality of the work that is being done. It is already a wonderful quality, but it's just the better coordination between specialties which will bring about a great thing. And this video competition has played a great role. Silver Jubilee, under the leadership of President Dr. Mukherjee and Dr. Mehul, has been a wonderful experience. It has brought the focus back on ocular trauma in the country, and we should take advantage of that to do these improvements for Indian ophthalmology and ocular trauma. Thank you.
So, we will start with the entry segment and adnexal injury videos. The first participant will be Dr. John Sarkar, who has to describe the video. Our team will play the video. Video will be 3 minutes and then we'll start discussing.
Okay, sir.
Dr. John Sarkar.
Yes, sir. Am I audible, sir?
Yes.
Thank you. Thank you, sir.
Little bit of introduction, please.
Just
one line.
Minimize karo din.
One line introduction for each participant.
Dr. Sarkar, introduce yourself very brief.
A very good evening to all of you. Myself, Dr. John Sarkar. I did my cornea fellowship from Shankar Netrala, Chennai, and I was working as a junior consultant over there. Presently, I'm in Shushu Eye Foundation in Kolkata as a anthosegment cornea cataract and diffractive services. And this is a 3 minutes video, but it's a journey of me with this patient for more than 3 months. And I'm very much thankful to my patient. Please enjoy the video. Can I start my slides?
Sure.
Am I audible?
Yes, yes.
Yes, sir.
Can I start?
Yeah, please.
Very good evening to all of you. I'll be presenting melted by Morton, melted by Conway salvage. I have no financial interest. 45 ml presented with melted by Morton metal, but can be salvaged. I have no financial interest. A 45-year male present in a hospital with left a sudden drop of vision for pain for 1 week with accidental injury by molten metal while working in a factory with no significant medical past history, and also it was managed by only clinical medication. On clinical examination, left eye VCVA 6 by 60 by N36. With inferior on clinical examination, there is a limbal ischemia involvement 2 to 9 clock or involvement with near total epithelial defect, inferior ischemia with the overall grading of the grade 4, there was grading with inferior ischemia. My immediate management was emergency tenor advancement with the amniotic membrane transplantation on the same day under general anesthesia. In spite of the aggressive medication, the progressive scleral ischemia is noted post-operatively. So my second surgical plan was scleral patch drop or SPG under local anesthesia. Demarcation of zone of scleral ischemia with the debridement of the necrotic tissue. Conjunctival autograft or CG harvesting from the healthy supravalvular part of the same eye without disturbing the residual limbal stem cell. Demarcation on marking of the scleral part. SPG is prepared by the gentle and the steady dissection of the sclera with the crescent knife with the help of assistant who grabs the four corner of the sclera. SPG prepared is placed over thinned out scleral part, secured with fibrin glue, and it is ironing to make it in the shape of the contour of the eye. Additional 4 sutures was given by 7-inch of acrylic suture, and it gives the anatomical integrity of thinned out scleral part. A amniotic membrane was placed under whole ocular surface, which acts as the basement membrane of a newly reconstructed ocular surface. CG, which is I already have harvested, placed in the inferior part of the globe and secured with the fibrin glue. An alloslit was prepared from the cadaver eye and make it in small pieces by Vanna's knife and placed in the inferior limbus, which acts as needles for the regeneration of the corneal epithelium. Now it's become the reconstructed new ocular surface. My immediate post-op was uneventful on the post-op day 1. At the 6 weeks, cornea was clear, the eye was quite moist with no symboliferum, with the VCVA 6 by 9 and 6. And it has been maintained 6 by 6 and 6 over a period of 6-month follow-up with clear cornea white eye. So in conclusion, chemical injury management should be in the molecular and the cellular level. SPG a novel technique to salvage the eye. Thank you very much for your kind patience, sharing.
John, can I ask you one question?
Yes, sir. Please, sir.
This scleral patch graft that you did, that was with the fresh sclera or with the preserved sclera?
Sorry, sir.
The sclera that
Pardon,
you
sir?
used, the sclera that you used was a fresh one or it was a preserved one?
It's a preserved one, sir. It's a preserved one.
Okay, second point that I saw that after putting those slates on the surface, you did not cover with any bandage contact lens.
Yeah, it's covered, is sir. I covered the bandage cut BCL, 18 mm BCL was given, and the temporarily one suture tassography is done.
Okay, and third point is, what was the metal?
Pardon, sir?
What was the metal?
Its patient was working, yes, sir. It's aluminum hydroxide, sir.
So why do you say it is a chemical injury, chemical type of reaction? In the last slide, you saw that chemical.
Sir, it's actually alloy was there. It's a molten metal with the patient having the chemical. This is a mixed alloy was there injury.
You better should have stick to the metal only rather than commenting onto the chemical or the nature of the metal, because you have not tested the pH of the metal.
Okay, sir. Okay, sir.
John, it'll be more likely, as Dr. Mukherjee said, a thermal injury rather than a chemical injury. More of a thermal injury, because it must be molten metal would have caused a huge thermal damage and the resultant ischemia. But you managed it beautifully, and it has given a wonderful result in a very difficult situation. Have you used this technique in other cases? Do you have a number of series or anything?
Yes, sir. Yes, sir.
And give us some idea of what the results are like.
It's actually, sir, I have a series of chemical injury patients. As of now, I have done. It's actually whenever I consider the uniocular injury, we have the taking the stem cell from the other also allows all of your slate. And I have done almost 5 of the patients chemical injury, and which came to us as a tertiary eye care center as a in the intermediate stage. They need the actual intermediate care. Come with the surface inflammation. We treat the
Intermediate
surface.
would imply how much time after the injury?
Actually, they come around the most of the time on an average. I have seen the whatever the 5 patients I have done, it's approximately come to us after 6 weeks from in between 1 month to 3 month 4 month duration. Mean duration between the injury to come visit to in our hospital, on an average it's 6 weeks to 3 months.
So have you done any more scleral grafts in them? Or
Actually, scleral graft this for this patient, another patient I have done only whenever there is a severe scleral ischemia, and then definitely I have to do this. The only 5 out of 5 patients. This patient, one of this patient, I'm very much attached with this patient because this is 3 minutes video, but I have a journey for the more than 3 months.
so scleral patch graft is only a kind of tectonic support for the lost tissue. The other things that you've done, including the amniotic membrane graft, conjunctival graft, and the limbal cell
Yes, sir.
placed, I think those are the real things which have helped in the regeneration of the epithelium.
Exactly, sir.
I
Yes,
think
sir.
this technique we can describe as a slat.
Yes, sir.
And the slat, we have published a series of a slat in Indian Journal of Ophthalmology.
Yes, sir.
Given very good result.
Yes, sir.
For the chemical
Actually,
injuries, Dr. Mehul,
Yeah, for chemical injuries.
at what stage have you used them? Acute stage or
I am not the
intermediate?
corneal people as used, but I was part of that publication.
Okay.
uh,
Generally, at what stage?
may I, sir?
Acute.
Acute stage.
So
Acute.
late can be done on either way. You see, either in acute condition, intermediate condition, or even on the late condition in order to repair the surface,
Okay.
ocular surface. So late has no indication like that. Only you can use in acute condition.
Next candidate, can we go ahead?
Can I ask one question, Megal?
Yeah.
John, I think it is a
Yes,
very
sir.
video, very nice video. Congratulations. I
Yes,
just
sir.
want to, what is the post-operative regimen for these patients?
Sir, very nice. Sir, initially, actually, I give the patient 0.1% betamethasone eye drops with the for heparin dose for the 6 weeks, and the other eye, and along with this copious lubrication with cycloplasia, and along with the we give the care your orally doxycycline is given, and the prednisolone and oral Vizon is given for a tapering fashion.
Okay, sir. Thank you.
Thank you, sir.
Can we go ahead with the next?
Yeah.
Yes, join the sir. Yes, join the sir. Right.
Jayant, you are muted.
Muted. Jayant is muted.
Hello. Yeah.
Yes, join the sir.
Yeah. As per the textbook, a textbook and we should not use a 2 graph, but in your result you use 2 graph, scleral graft as well as that amniotic membrane graft all. So, but your results are very good. Is there any other options?
Sir, with due respect, actually, if you follow the grammar of the ocular surface reconstruction, why I am giving the scleral patch in this patient? Because it's not that randomly I have decided on table. I pre-operatively I had drawn the diagram for which thing what supposed to be pre-operatively. I have a fixed plan in my mind what I am doing going to operate this patient. This patient showing the significant scleral ischemia with the more than I have done the associative. I can't show this because it was not very much reproducible, and it's showing the more than 50% thinning is there. If I would have just simply give the AMT, I know invariably it will melt it off because already when the patient come with the intermediate stage with us, I have done the tenonplasty, it was not salvaged. So that to give the anatomical support, I have given the patient the half thickness scleral patch graft. On top of it, I give it the AMT, which acts as the basement membrane. And if on over it, I give the some of the conjunctival your CHE. I know some of the residual conjunctival stem cell is there from the furnaces, which can grow it from over this new basement membrane, and the whichever I have given ready-made source of the CHE, which can also grow. And I know there is a definitely persistent epithelial defects because the second surgery was done on almost near after 1 month, and there's some sorts of there is no surface inflammation. What the Mukherjee sir was telling that definitely I do 100% agree with the sir. We can give it in the acute stage, subacute stage, and the and your chronic stage, provided you should give the proper immunosuppression to the patient. There should not be any surface inflammation. Definitely, stem cell will give the 100% predictable outcome. In my short experience, I have done 4 or 5 patients, but the Grover sir was asking, I got the predictable outcome.
Excellent, excellent, excellent.
Our next candidate is Dr. Anita
Doctor,
Venugopal.
excuse me. Sorry to interrupt, doctor. I would request the judges to post the marks.
Right. Entry
Thank you
segment
very,
judges, kindly post the marks.
thank you very much, sir. Thanks to everyone for your patient sharing.
All the best.
Our next contestant is Dr. Anita Venugopal.
Could I play the video?
Dr. Anita? Dr. Anita is... she is there or not?
She was there, but I think she's muted.
I think, Mehul,
Yeah.
what you can do, you can just
She's there.
announce the name of the next speaker just at the beginning of the present speaker. That will be better.
Anita is there. I think she
Anita
is
is
there.
there. She's muted, I think.
She is muted.
Please unmute yourself, Anita.
Dr. Anita, you need to do a join audio because I think so you have not joined your audio. Doctor, can we go to the next speaker so that I can talk to
Yeah,
Dr.
next-
Anita?
You can talk to her and get it sorted.
Next person is Dr. Rashmi Krishnamurthy.
Good evening, all. Can you hear me?
Yeah.
Yeah,
Yes,
Is it
ma'am.
Rashmi?
Yeah, I'm Dr. Rashmi Krishnamurthy. I did my glaucoma fellowship from LV Prasad Eye Institute in 2014, and presently I'm working as a consultant at LV Prasad Eye Institute in glaucoma and cataract services. So I'll be presenting a video. This boy had a blunt injury, 14-year-old boy, had high pressures and total cataract, and trabeculectomy done and bleb needling done, which had failed. So we planned an RD and a cataract surgery. So after the corneal traction suture, the conjunctival opening was done limbal base around 5 mm from the limbus. And then the lateral rectus and the superior rectus muscles were identified and good dissection under the muscles done. After the priming of the tube, the plate was fixed underneath the muscle, and it was fixed with a non-observable 90 proline suture, and the suture was buried. Then the tube was fixed with 10-0 nylon suture. Because it's a non-gnarled implant, it's important that we ligate the tube to prevent the initial postoperative hypertonic. This is done with 6-0 Weichel suture, and there is complete occlusion of the tube. This is the second ligature to confirm that there is total occlusion. It opens at around 40 days. Next, the venting incision is given to prevent the early postoperative IOP spikes. After this step, the lens aspiration is proceeded. This was a membranous cataract where there was already a pre-existing anterior lens capsule tear, and there was addition between the pupil and the which is released with a repositor. And then this is slowly, meticulously, the anterior lens capsule was removed with the microforceps. The residual cortex was hydrated, and then the cortical aspiration was completed. So there was a tear in the posterior capsule which was noted at around 7 o'clock to 8 o'clock, but there was no vitreous disturbance. So the IOL was placed in the bag in the sulcus. It was tucked behind the iris, and then rest of the implant steps were completed. So 23 gauge anterior chamber entry is done. And then the tube is cut according to appropriate length, and it is inserted into the anterior chamber with a tube inserter. The tube length was little longer, so it was taken a curved course in the sclera, and it is sutured with a 10-0 nylon. and then the tube is covered with a donor scleral patch graft, and the conjunctiva was closed with a continuous suture. Once this was done, the ports were sutured with a thorough visco wash. You can note that the tube is there in the anterior chamber. And post-operatively, the patient did well. There was a residual PCO. At the end of 6 months, it was YAC. And without any AGM, the patient is doing well with 20/20 vision and good IOP control now. The fundus is normal. There was no disc damage. Thank you.
Thank you. Good presentation.
Thank you, sir.
Any question from Dr. Parihar? Dr. Parihar there?
I thought to give comments in the first case also, and the second one is nicely managed. The only comment which I would say that when the tube was large in the size, it is always better to take it out, trim it and put it again. Because when it is kinked one, there is a strong possibility that this tube may get loose and again it looks larger and may have the corneal problem subsequently. So I always believe if the tube length is too big, it is better to withdraw it again.
Yeah, so initially when I started doing the implant, I used to remove the tube and cut the tube and put it, sir. But then with time, just a little bit curved course on the sclera and just fixing it with 10-0 nylon. Till now, it has not caused any problems, but I do agree that we can remove the tube and trim the tube and then put it back into the eye. Thank you.
See, this child is a pediatric case. We expect that every patient of this age would survive for next 75 years. So all changes in these tubes, basically the thinning of sclera and the tube erosion problems may come if the tube is kinked after 5 to 7 years. So that is the reason it is better that it is withdrawn and put it again.
Sure.
And I think as a pediatric patient, we need to do the primary posterior capsulotomy and vitrectomy.
Yeah.
That might.
Yeah, but because I'm not a pediatric surgeon as such, so when I did the initial implant and then along with the lens aspiration, and he was very cooperative. He was a 14-year-old child. So I'm not trained in doing a primary posterior capsulotomy. So I felt this is safe. And later at 6 months follow-up, did a yak cap, and he had come recently at 1 year. He's doing well. I do agree that I should have done primarily, but because I'm not trained in doing it, I did not do it.
At 14, it may not really be essential when the child is.
Yes. 14 is an adult.
14 years, yes.
Can I ask one question, Madhu?
14 is an adult.
Yeah.
Rashmi, very nicely done. I just want to know, because it is a small pupil. Why didn't you dilate the pupil? So
no, it was dilated because there was adhesions between the pupil and anterior lens capsule.
Mechanically, because before I implant a lens, either in the bag or in the sulcus in a small pupil, I always make sure, especially in a child like this, and I make sure that the pupil is mechanically dilated, either with the iris hooks or something like that, to make sure that you are right in the bag there, and you want to see the periphery, you want to see the sulcus as well before you put a lens there. And the pupil is also a little irregular there, probably because of the additions. The posterior synechiae was there at that time.
Yes, initially there was, but when I started doing the lens aspiration, the pupil had dilated, mid-dilated, so I didn't feel that there's a need to put. But to see the view of the capsule and the sulcus in the back, I should have used the iris hook. I did a Kuglin's sphincterotomy, but like iris hook would have been a better.
Stretching also probably would have given you that slightly better view, but
yes,
but absolutely beautifully managed.
Very well managed, Dr. Rashmi. When would you rather choose an implant rather than trabeculectomy with mitomycin C?
This boy had already undergone a trabeculectomy and a bleb needling, which had failed. So because in the primary fitting, they had just planned a trabeculectomy without lens aspiration. When I did, I didn't feel that we should postpone the lens aspiration again. So I combined the implant along with the lens aspiration.
Good decision.
Thank you.
Dr. Grover, sir, I would like to add here that if it is a case of refractory glaucoma and early adulthood, if the patient is already on more than 3 drugs and the intraocular pressure is beyond 27 despite multiple drugs for more than 2 weeks, it is always better to go with the implant rather than trabeculectomy, because that is going to be invariably give the poor results in these type of cases.
I agree. And in
So
children,
choice of implant is absolutely fine.
agree.
Choice of going for implant is okay.
Yes, Dr. Payal. He already had a failed trab in just 3 months, so which was
I'm supporting
managed
you.
elsewhere. Yes,
I'm
thank you.
I would have done it as I would have done as a primary implant in this
Thank
case.
you. Okay, thank you.
Maybe move to the next, Dr. Noble.
Thank you, everyone.
I'm sharing Dr. Anita Venugopal's video, doctor.
Yeah.
Yes, sir. Yes, sir. Good evening, everyone. Am I audible now?
Yes.
Thank you. I'm Dr. Anita Venugopal, working as a consultant from Aravind Eye Hospitals, Tirunelveli. Can we start, sir?
Hello.
Yes. I'm presenting a case of a surgical removal of an epithelial ingrowth and flap revision of post-traumatic dislodged LASIK flap. A 33-year-old female patient presented to us with a folded and dislodged LASIK flap with central extensive epithelial ingrowth following trauma with a child's finger. She underwent LASIK 10 years back. Now, the surgery went on with an epithelial debridement with using an alcohol sponge. And the flap edge was identified with a spatula that was a femto LASIK spatula which I used, and the flap edge was fully identified and it was lifted, and the video was passed. Okay. The folded flap edge was also identified and lifted, and the challenge here was the LASIK was folded like 1 month back. So the patient had come after 1 month of trauma. So unfolding the flap was also a challenge to us. And the epithelium, intact epithelium around the LASIK flap margin also was removed to 100% ensure that the epithelial ingrowth doesn't occur in future. And the flap stromal bed also was thoroughly cleaned of the epithelial ingrowth. The epithelium ingrowth, it appears as a epithelial sheet. So identifying the epithelial sheet also would be a difficult procedure, and even it is not possible to completely ensure that all the epithelium has come out. So careful and gentle scraping of the epithelium from the backside of the flap was also done. Thorough saline wash was done over the stromal bed and the flap was reposited. The fixed fold, which was 1 month old, was difficult to stretch. So we used dry sponges and stretched the fixed fold on the opposite direction, and the flap was completely ironed out all over and ensured that it was well opposed. And the flap suturing was done in my case because there are many other methods of flap reposition. Like we can use a hydrogel sealant or fibrin glue also. But suturing, it helps us in 2 ways. In complete opposition of the flap, and we also can ensure that no epithelial ingrowth recurs after the opposition. A BCL was placed over and for the epithelium, aid the epithelium to grow back, and then under topical antibiotic was applied. This is a picture of a 1 week old flap reposited eye, which was clear with a clear interface with sutures intact. Thank you for the opportunity.
Yeah, it is well managed. I'm Dr. Parihar speaking. Yeah, Dr. Anita, you have well managed this case, and I have to one observation and one comment. Now, this
Yes,
LASIK
sir.
flap is such a thing that with trauma, it can always has a possibility of dislodge. We
Yes, sir.
remember this flap that shifted after having playing in the boxing games. I remember I did earlier. I was with VR in 2009. I was doing one young girl for the macular hole surgery who has undergone uh, LASIK, and during that procedure itself, the flap was dislodged. So the flap dislodge is the issue with the LASIK, and that is why it was not considered ideal for armed forces in the services. Second, the question for you is about how to prevent the further epithelial ingrowth in these cases. Would you prefer to use MMC on table or subsequently in the post-operative period or some other method?
Sir,
Dr. Anita, please.
sorry, sir. Sir, second question I was able to hear fully, sir, but first question I don't know. I didn't hear it
No, no,
properly,
there is
sir. Okay, sir.
there is only one question for
Yes,
you.
sir. Yes, sir. Sir, actually, I ensured a complete epithelial debridement, sir, from the stromal bed and as well as the flap, because the epithelial ingrowth will appear as a sheet, as if like we are removing epithelium from a PRK patient. So it will appear as a sheet. So I wish I try to find out any epithelial drag is there even after thorough BSS wash, and repeatedly I was viewing for any epithelial tag during surgery. And then
Because in
and the epithelium around the flap margins also I removed
am I
because it should
audible?
not grow over. Yes, sir.
Yes, sir.
I think
Yes, sir.
Dr. Parihar's question was, how are you going to be sure that there is no recurrence of the similar type of situation in future?
Sir, because I'm sure that because the epithelial, the LASIK flap was well opposed, sir, after the surgery, and after removal of the epithelium also, the suture also, there was the epithelium healed, the flap edge healed well. So by that, I ensure that there won't be a epithelial growth, and we follow the patient regularly, sir, with the treatment.
In most of the center, it is a practice that before placing the LASIK flap, even in a first surgery, that 0.01% MMC is used.
Yes, sir. I understand, sir, but I don't see I may cause a stromal melt or something like that. Maybe
It
a
doesn't.
complication. Maybe
It
okay.
doesn't cost. It doesn't cost.
Yes, sir.
We should
I've
have
never
used
used.
MMC,
Okay, sir.
but I think the technique which you have adopted to completely thoroughly scrape the epithelium from
Yes,
the
sir.
stromal band, that is
Yes,
good.
sir.
And in my experience, if you have removed the epithelium from the surface
Yes, sir.
before removing before lifting the flap, that will ensure the wrinkling what you have seen, the wrinkles which were there in the flap, that automatically once you have spread it out, then these folds or wrinkles in the flap, they disappear, and you don't have to do a lot of spreading or scraping or the ironing of the flap. Is that is, I think after the BCL, the flap folds on microstria, they all disappear.
Yes, sir. Yes, sir.
But mitomycin C, I think I am using in all these cases of epithelial ingrowth.
Yes, sir.
Can I make one comment, Miguel?
Yeah, yeah.
I think
Please go
Brenda,
ahead.
you were talking about because the femto-LASIK is much thinner than the regular LASIK, and that's probably the reason why the wrinkles are there. And it's very difficult to because femto-LASIK very rarely has a problem like this. But regular LASIK flaps, I think, is easier to do that. And but I feel that mitomycin C, there's an absolute indication for this in this condition.
Yes, sir. In future, I will definitely use it, sir. Thank you.
Very well done.
Thank you, sir. Thank you.
Next is a keynote address by Dr. Rupesh Agrawal. Rupesh, are you there?
Thank you, Dr. Mehul.
Rupesh does not need any introduction. He is a secretary of International Society of Ocular Trauma, as well as founder member of Asia Pacific Ocular Trauma Society, and he is very active supporter of Ocular Trauma Society of India. He have a very great experience in ocular trauma. He is well published. I think he has got a very large number of articles published in all peer-reviewed journal, including highly rated and high impact journals. So we are fortunate to have him here today with us. Rupesh, please.
Thank you, Dr. Mehul, and it's my real pleasure. And I remember my journey. We started together in Rome probably 15 years ago. Anyway, just to get back to the topic, I would like to thank Ocular Trauma Society of India, Dr. Mukherjee, Dr. Grover sir, Dr. Purendra Besin sir, and all my dear friends here. It's always a pleasure to be back with Ocular Trauma Society of India. So I feel at home basically whenever I'm with Ocular Trauma Society of India. Friends, I'll be touching base on some of the very important and fundamental aspects, and you may see this seems to be very, very simple things, but believe me or not, when you start practicing on ocular trauma or managing some of these cases, you will find this small little tips of do's and don'ts can be quite helpful when you go through the journey of ocular trauma. And this is based on some of the mistakes I've done myself and mistakes we have picked up through some of our colleagues and friends, and some of the things which we thought will be useful. So I used to try to keep all those videos wherever after reviewing, I think it's a mistake. So therefore, that can be quite an interesting thing when you try to review your video. So the basic context, as Dr. Grover sir has already laid in his inaugural speech for today's session, is that for ocular trauma, unfortunately, we don't have a defined fellowship. So unfortunately, as soon as you enter into a fellowship, and Dr. Rasmi will agree with me at LB Prasad also, that you are the certified trauma surgeon there and is the junior most. So this is where we go there. Cataract, you have to have a certain number of surgeries. FEM2, you have to have a certain number of phaco's to be done. Cornea, retina, glaucoma, oculoplasty, you have to have a fellowship. But unfortunately, within day 60 of residency, you are a certified independent ocular trauma surgeon. And some of these things will be quite useful as we see some of these cases being managed, and you can see the basics are not being followed. And this is where you can go terribly wrong. And this were all, I always call it, this is a virgin eyes to start with. And unfortunately, those has not been respected. And Mehul, you can interrupt me whenever I'm done with my time. So just let's start with some of the videos and animations and all. So this is a very simple video clip. In case if you would have missed, I will be randomly showing, and this is how the vitreous is coming out of this scleral wound. And probably you need to make sure that the vitreous has been cut. And we have seen cases where, and Dr. Mohan Rajan sir, who is on the board, he will definitely agree that the people have stitched the vitreous within the wound, and then that can result into detachment of the retina and all sort of complication. Again, here it is like freshening of the wound edge, making sure that the wound are cleaned. Sometimes it is bleeding a lot, it may be difficult, but at the same time, you have to make sure that you are not suturing iris and all those things. And probably that is because of this precision and all, the rates of sympathetic ophthalmia has gone down. And any of the resident who is attending, if you can answer me, what was the surgery which has the maximum number of sympathetic ophthalmia? So I think those probably who are reading it, they will know that there is a surgery called as iridonclasis, and that has the maximum number of sympathetic ophthalmia following the surgery. And then you don't want to cause iridonclasis while you are doing a trauma repair. You want to do a clean repair. So probably Dr. Basin will agree, and probably will touch some of the points based on this thing. Moving forward, the corneal wounds are edematous, and when you do suturing, you have to make sure that that has been accounted for. And when you take suturing, you have to make sure that your sutures are adequately tight so that next day you don't get a loose suture. I had that few cases, and one of the cases I distinctly remember when I was in Jalna, Ganpati Netralaya. One of the cases I operated next day was suture loose, and then finally we figured out that patient has Ehlers-Danlos syndrome, which was completely missed pre-operatively. And every time I put it a tight suture, it will become loose next day. So that was one of the very interesting young boy whom I operated way back in my practice. The wound need to be sufficiently tightened enough, and the retina surgeons are not going to like this if your wounds are like throwing all over, and then they need to repair the cornea and all. And should not be too tight. Again, like in this case, you can see the wound will be very tight, and then you don't want that wound to be too tight, because that will again affect. And then therefore you have to remember that cornea is still a refractive organ, and you just don't want to close it off anything, whatever you like to have it. Something blocking the knot. So I'm not going to go into the detail, and you all know, and therefore sometimes it becomes important that you have gone through the ECI. So when I was joining Shankar Netralaya, I thought FACO is something which is going to happen and how I'm going to learn the suturing. But luckily in Shankar Netralaya, they taught us to do ECI before we went on to the FACO or SICS. So I still believe ECCE is a very, very important thing, and one should really practice suturing, because at some stage in your career, you will be required to do suturing. And at that stage, you don't want that. I have always, and I have seen surgeons in my community practice where I go places to places, whether it is Nepal or India or Cambodia and all. I've seen people who have never done a ECC, they struggle when they have to extend the wound. So Dr. Grover sir would have many experience related to this, and probably he can share some of these experiences when people struggle to put sutures there. So how do we do initial suture? We all know that, but again, just to exemplify and demonstrate, this can be one of the ways, though may not be correct, that you are doing the apex suturing, but sometimes the wound is so bad that you just want to give it some shape, and then just want to get the things back in the place. But here again, we are creating the triangular bed. So one is at the apex, one is at the base, and then the second one is at the apex again. So you can see these were not the titanium instruments which you will love to have, but this is done surgery many years before, and those days we never used to have a privilege of having any kind of a titanium. Now let's move our attention to the picture on the right again. This is all the things coming out of the thing, and again, identifying the landmark is the key important. And I have seen cases going miserably wrong when the people forget to identify the landmark. So the first step and the foremost step is to make sure that your limbus, and then that forms a very important landmark. So you think of your GPS. In GPS, you put a landmark where you want to go, and after that, the life becomes simpler. So let's move on. So Dr. Mehul, just remember to stop me whenever you think so.
I'll do that.
Yeah. Just again, getting back to the wound alignment. So this is a zigzag wound. Again, all of you would have seen this case, but seen the encounter cases like this, and you can see how there are different ways. You can always first, something which you should not be doing. This guy is going through that, and this guy is just me only. In my early days, inflating the chamber through the wound, which is not recommended. So that's one of those don'ts. And trying to kind of get the limbus back in the action. So once your limbus is back, again, there are different ways you can cut the suture and all. Now, again, here you could have gone to the second limbus. That would have been ideal. But again, the surgeon who is me is just trying to cut, make it into different segments. This is segment number 1. And now we are starting with the segment number 2. All the sutures are radial to the wound, as you can see very clearly. So again, just getting the radial sutures. And again, this is a radial suture segmenting the second segment. And then we'll have 3 segments. So basically what we have done for a corneal wound from limbus to limbus, we are divided into 3 different segments, and then the wound becomes easier, that as if you are doing the suturing of the 3 different wounds. Again, here, identifying the limbus and getting that right is correct. I'll just move on to the next video quickly. Here it is a retraction of the scleral lips. So this is again a very important concept, and a lot of people, they mistake. The scleral lips can get inside retracted, and you have to make sure that the scleral lips are taken care of and it is not growing. And I trust me or not, a lot of times I have struggled in my early days to identify what is the correct, is it a scleral edge, or is it the inside part of the sclera, is it the outside part of the sclera. A lot of times you will be struggling to figure out in the chronic wound like this thing. This wound was probably after 48 hours, and by the time the wounds would have retracted inside, and then edges would have retracted inside, and then it becomes very difficult. So these are some of the, again, fundamental things where you have to make sure that you identify correctly the scleral wound edges and make sure that you are repairing it in properly. I'm not going into the details of it, but again, you are just doing pulling and not pushing to prevent damage to the structures inside the eye. So therefore, you have to remember, you have to do atraumatic. I always like the word, and which I used to do it repeatedly, coin to the resident, is do a atraumatic repair of this thing. Again, something which you should not be doing. You see, this is a child, 8-year-old, the surgeon, and then it's causing the prolapse of the intraocular contents. while the surgeon is trying to insert from there. But this is a much better technique, as you can see very clearly. Going through a side port, paracentesis, delineating the wound, and going inside is just doing it. Again, just trying to keep into the theme of the video thing, because this is a video-based presentation and a video competition. So I thought I'll just show different videos. Again, maneuvering, but I'll bring it to the last part of this video where the surgeon is trying to do excessive maneuvering inside, and that is where it will not be recommended. So this is almost done. Everything is done. But then how the maneuvering was done here, and then the wound started prolapsing out these things from inside. Sorry, I missed that part, I think. Yeah. So this is some correct way maybe when you are trying to repair, and how you should do maneuvering of the hyphema inside the eye in a correct way. Okay. And then the last one of the videos is the rectus muscle, but we'll skip this, not something which you like to do. But this is the last one. And just a word of caution, some people like to take traction sutures. So this is the anterior scleral lip. Someone is trying to take a traction suture and you see what is happening. So this is not advisable. This spouting coming out of the scleral intraocular content is not something advisable. Again, you watch out this video. So this is again one of the videos I was doing. I was operating, and this is iris tissue prolapsing. I am just very enthusiastically cutting the thing, whatever is coming out, and just not wondering. See, this is kind of a partial expulsive hemorrhage which happens, and if you're not careful, and I should have probably put some sutures there before I goes inside details of it and try to kind of repair. So some of the animated videos was from Mr. Paul Sullivan from Moorfields Eye Hospital. With that, I'll thanks once again Ocular Trauma Society of India and all my mentors who have been sitting on this dais for training me and teaching me. But of course, I learned a lot from all of you, and you presented some of the very interesting videos, and I look forward to listen more from you. Thank you very much once again. Thank you.
Thank you, Rupesh.
Thank you, Rupesh, for having brought videos from different generations, including your residency days and early days. That was nice. I mean, a very important learning for us. And I think we must thank you for the pioneering role you are playing in bringing the ocular trauma specialists from all over the world together. And your role is really appreciable. You have really brought ocular trauma to the fore in the world. And I think that will really pay rich dividends to us in managing things well. You talked about the era of suturing. We used to call suturing the signatures of the surgeon on the eye, and now
yes,
everything is all checks are without signature.
Digital world.
Having gone through the generation of 6-0 sutures, no microsurgery, to 8-0 to 10-0 to sutureless, it's been a wonderful journey, and your videos were reminiscent of the journey that we've had in management, from the relatively difficult, crude ones to the sophistication of today's microsurgery. Thank you for bringing out how the generational change has taken place and how the present management has evolved.
Thank you, sir. Thank you, sir.
This talk is very important for the younger generation.
Very nice.
That's why I requested Rupesh to speak on this, because I heard once was speaking something like this, and this is very important and educative to all of us, not only the younger generation but everybody. Everybody should learn by their mistakes, and Rupesh has done that. Now Rupesh is absolutely accomplishing surgery. Thank you, Rupesh, for accepting OTSI invitation.
Thank you, sir. Honor.
Can we go ahead with the next candidate, Dr. Kirti?
Yes, yes, doctor. Am I audible?
Yeah.
Myself, I am Dr. Kirti, and I have done my post-graduation from Shankar Netralaya, and currently doing my glaucoma fellowship in LV Prasad Eye Institute, Hyderabad. So a 36-year-old gentleman presented to our glaucoma clinic with a pressure of 54 millimeters of mercury on maximum medical therapy. In view of naive conjunctiva, we decided to do trabeculectomy for him, and superior rectus bradal suture was taken. As you can see, fornix-based conjunctival flap was carefully dissected, and Blunt dissection was carried out using Westcott scissors. Gentle bipolar cautery is done over to avoid and at the same time tissue charring and tissue contraction should not happen. And with 11 number blade, a broad based triangular flap was raised and a partial thickness triangular flap was dissected, carefully dissected using a 15 number blade. Uh, 0.4 milligram per ml mitomycin C was used for 2 minutes and a pre-placed apical suture was taken. Ostium was made using MVR blade and Vanna scissors. And as you can see, as soon as the ostium was, the edges of sclerectomy was done, you can see the iris is bulging. And as soon as the peripheral iridectomy was done, you can see a blob of vitreous prolapsing from the wound. And this was expected from the, in this case, as this patient had preoperatively subtle phacodonosis. So vitrectomy was performed in this case, making sure initially the vitrectomy was performed at the wound. And once the vitrectomy at the wound was completed, we entered the wound from the site of iridectomy. And then here it is important to make sure that the vitreous probe is pointing towards the lens. And as you can see, air bubble was placed to prevent chamber fluctuations. And when the sponge was placed, the vitreous was still coming out. So adequate vitrectomy was completed and made sure that there is no vitreous blocking the ostium. And then the triangular flap was closed and watertight closure was performed using 80 polygalactin sutures. And this patient on postoperative day 1 was doing well, and at 1 month also is doing well with well-controlled intraocular pressure with no medications postoperatively. And so vitreous prolapse was expected in this case, and the most important thing in this video is to know how much and where to stop the vitrectomy to not do not do more vitrectomy, and at the same time it has to be adequate and make sure that vitreous does not block the ostium postoperatively.
What was the cause of refractory glaucoma in this case?
There could be multiple factors. First of all, the patient initially had traumatic uveitis also. So we were giving him oral steroids also to control the inflammation. So one could be steroid response, and also he had angle recession also in the superior quadrant. So because of this, his pressures were not under control.
How much was angle recession?
Actually, only one quadrant, superior quadrant of angle.
So
yeah.
That doesn't give two rise in pressure. And what you had mentioned about phacodonesis.
Yes,
so,
doctor.
There was no cataract formation in this?
Yeah, actually, exactly what happened was preoperatively, the patient had mild PSC and also patient had PCR temporally. So we did not attempt a combined surgery. And after trabeculectomy, within 2 months, the patient actually presented with a total cataract. So
they should have been brought forward, because I presume if there is a trauma, young individual and pressure is shooting up, phacodonesis, so lens management should have been done. And I'm surprised if for 2 months, if there was a PCR, the pressure remains under control after surgery. So now I recollect it on the going through it. It is probably the phacomorphic glaucoma because of the injury. The trauma of less than one quadrant does not give the raised intraocular pressure. Second thing, have you used mannitol before surgery in this case?
Yes, doctor. Yes, we have used.
That has not been specified. And how much was the pressure when you started surgery?
That we usually don't take
No,
preoperative
because
IOP.
pre-operative 54, how can you open up for the trabeculectomy? You are
No,
bound to
doctor.
have the problems. So
No.
if the pressure has been reduced, it should have been brought forward. Second,
Yes.
if the vitreous has come in the iris wound,
Yes.
iridectomy wound, so
Yes.
whatever vitrectomy you do it, once the vitreous is deranged, the young individual is likely to have retinal problems also because of the vitreous traction
Yes.
and fibrosis. So
Yes.
I think this management per se is not as per the I would say the copybook style of managing a traumatic cataract with PCR with the refractory glaucoma. The management
Okay.
should have been here. This type of patients require a lens management with the posterior segment surgeon, good vitrectomy, so that there is a no possibility of the vitreous traction, retinal detachment, ERM formation, and I would have preferred to go with the tube in this type of cases. Now you follow up these cases, and probably after 3 years or so, there might be some problems which may come forward. This needs a long follow up actually.
Yes, sure.
I think even if you have tried to do trabeculectomy, you could have done the 8-drop vitrectomy. Without irrigation, you could have did the central vitrectomy, reduce the pressure before surgery, and then you could have gone with this.
Okay, sure, doctor. Sure.
Dr. Preeti, what is the reason that you place pre-placed suture for your apical triangle?
Yeah, but once we decompress the chamber, we don't want the hypotony to be there for a long time. So we just pre-place the suture so that we can take the suture immediately once we make the ostium, and we just the suture is ready to close it immediately. That is one of the major reasons why we take this pre-placed suture.
Just the matter of reducing the time for closure.
Yes.
I think anterior chamber maintainer also would have been good option.
Yes, yes, sure.
Can we move to the next one, Dr. Mehul?
Dr. Vanati, please.
Robert, can I ask one question to Preeti?
Sure, sure, man.
Yes, yes.
Why was the cataract not combined with the trabeculectomy?
Because initially he did not have that significant cataract. It was just PSC. But post-operatively, probably because of the hypertony and the intraoperative manipulation, the cataract had progressed significantly. And also we did not plan for combined surgeries because the patient is young patient, and the amount of inflammation with combined surgery again might result in trap failure. That's why we had done initially only trap, and then depending on the then we decided we will manage further.
In this case, as Parihar sir was telling, I think this phacodonosis, this is forming a major as far as the glaucoma is concerned. Apart from the angle recession, I think unless you take care of the lens, because lens is one of the causes for the glaucoma as well. So
Yes.
you have to take care of the lens. I thought we would have combined the lens. I would have combined the lens, the phaco with trabeculectomy in this particular case.
Okay.
And
Sure.
it manage the vitreous also much better.
Yeah.
Yes, yes, yes. Sure, doctor.
Hold on tight right there. Lift him up. Lift him up. Yeah. That's
Dr.
correct.
Mahati?
Yes, sir. Sir, am I audible, sir?
Yes.
I'm Dr. Mahati. I'm currently working as registrar at Sankara Eye Hospital, Guntur, in Department of Pediatric Ophthalmology and Strabismus. Now I'm going to share our experience of a patient with double muzzle injury with an intact globe. A 50-year-old male patient came with the complaints of double vision following injury to the left eye with an iron rod at workplace. Visual acuity is 6/6 in both eyes. Anterior segment and fundus was normal. In the left eye, a stump of lacerated inferior rectus muscle was seen rolled up with a retracted lower lid. The eye was elevated in adduction, and there was a restriction of depression and abduction of -5 and -4 respectively. We planned for wound exploration and repair. On table, an irregular 360 degrees paralimbal conjunctival tear was noted. We hooked the lateral rectus muscle, and a partial tear of the lateral rectus muscle was seen about 8 millimeters from the incision. The distal cut end of the lateral rectus muscle was sutured to the proximal end using 5-0 ethibond non-absorbable suture. Here we can see the lateral rectus muscle being sutured. Coming to inferior rectus, at that point we couldn't find the distal end of the cut inferior rectus, only the proximal end was seen rolled up. So the inferior oblique muscle was hooked. Using the muscle hooks, it was cut, and the medial end was secured with the suture. With this suture, when the inferior oblique muscle was drawn forward, we could see the cut distal end of the inferior rectus muscle. This cut end of the distal inferior rectus muscle was identified, and it was sutured to the proximal end anteriorly with the resection effect using 5-0 ethibond non-absorbable suture. Here we can see the inferior oblique muscle. Anterior transposition of the inferior oblique muscle was done, where it was sutured temporal to the insertion of inferior rectus muscle. Post-op day 1, there was an improvement of abduction and depression to -3. Post-op 1 week, the patient was ortho in primary gaze and there was no diplopia, and there was an improvement of abduction and depression. To conclude, multiple extraocular muscle injury with good visual acuity is a tricky and challenging situation for the surgeon, and patient needs to be treated meticulously. Thank you. Thank you for your patient listening, sir.
Very nice.
Thank you, sir.
Good management. Why did you think of the inferior oblique entero positioning?
Yes.
What was
Sir,
the direction? Yeah. I mean, not being pediatric ophthalmic surgeons, we need to just understand for our knowledge.
So first, actually, the site of injury was not at the insertion point of inferior rectus, sir. It was very distal, around 7 to 8 millimeters posterior to the insertion. So we couldn't find the distal end. Our first thought was doing the anterior transposition of inferior oblique muscle, where we are converting it into a depressor. But then we disinserted the inferior oblique muscle. We found the inferior rectus muscle. Usually the inferior rectus muscle is attached to the suspensory ligament of Lockwood at that place.
So it
again, we traced
helps to disinsert the inferior oblique muscle, and that helps you to bring the two muscles together and find the end of the inferior rectus. Is it a known thing, or did you improvise that?
We improvised it, sir. This was not documented anywhere. We first thought we'll do just an inferior oblique anterior transposition because we are not able to find, but we gave an attempt to trace the inferior rectus muscle because that is the place where it is attached to the suspensory ligament of Lockwood. So we thought we'll explore some more, and when we explored, we were lucky enough to find the distal cut end of the inferior rectus
If
muscle.
you were able to put back the inferior rectus as well, then why did you need an antero positioning of the inferior oblique?
Sir, this is a total muscle injury, and the end of the muscle was also necrosed, sir. So the
That's
effect
why you
of
did
the
a resection as well, a resection effect.
Yes, sir. Yes, sir. A resection was done.
If you
And
follow
the
the
intro positioning, how would it help?
possibility of getting muscle. If you
Sir,
follow the muscle sheath, there is a possibility of getting lost muscle.
Yes, sir. Sir, I can't hear you, sir. Mehul, sir.
If you follow the muscle sheath, there is a possibility to retrieve the lost muscle.
Yes, sir. That's what to follow the muscle sheet. If we had disinserted at the insertion, we would have had the sheet, sir. But since it was too posterior, only when we disinserted the oblique, we could find that sheet.
Correct.
So give us the logic for antero positioning of the inferior oblique.
Since it was an extensive injury and total muscle was cut, we thought we'd do an additional procedure and make the inferior oblique muscle a depressor by doing an anterior transposition.
So we were not sure of the inferior rectus action.
Yeah, true.
Yes.
So
Preoperative
additional help.
MRI was done. Preoperative
Sir,
MRI.
sir?
Preoperative MRI.
No, sir, we didn't do a preoperative MRI because no, sir, we didn't do an imaging. Actually, even that patient was not affordable, and we could see the rolled up cut end of the inferior rectus muscle. Also, directly we can visualize that.
Now, will it be useful, especially for the cut muscles like this?
Sir, had it been a surgical loss, we would have dissected all the ligaments beside, so the muscle would have gone so much posteriorly. But since because it is traumatic, that the side attachments and the muscles will be there, so the muscles would not have retracted. So it might not be a mandatory to take a MRI, but if need, can go ahead, sir, and take an MRI and locate the muscle where it's located.
Mahathi, what was the mode
Next
of
is Dr. Walda.
Sir, sir.
What was the mode of injury?
It was injured with an iron rod at workplace from laterally. He was working at his workplace. An iron rod came and hit his eye, sir.
Okay, so from the lateral side, we don't see any external wound on the skin.
No, sir. That was the surprise, sir. The eyeball was intact, only a 360 degrees conjunctival tear with muscles.
What do you think?
And the patient's only complaint was double vision.
I think was the cause for muscle laceration. It was the rod or the rotation of the globe.
It's more of the rotation of the globe, and the protective bells phenomenon might have occurred, exposing the inferior part of the globe for the injury over the muscle.
Any evidence to rule out optic neuropathy, traumatic neuropathy?
So this patient, the visual acuity was 6.6. There was no RAPD. His color vision was normal.
If the rotation of the globe is to that extent, that is the laceration of the muscle is there, so must have concussion injury to the optic nerve.
Sir,
So we need to document.
I can't hear you, sir. Sorry, sir.
So with an extensive damage to the.
Yes, sir. Anterior.
Am I audible?
Yes, sir. Yes, sir. Please, sir.
With an extensive rotation of the globe, there must be a concussion injury to the optic nerve. So do we bother to see post-operatively the optic nerve functions or any documentation for that? Because the people.
Yes, sir. Post surgical repair. So, as a first when he came to us, first time his pupil was normal. It was reacting. Visual acuity was 6.6. His color vision was normal, sir. So we went ahead with the repair. Even post repair also, his visual acuity was 6.6, sir, with a normal color vision.
Bhanati, in such situation, suppose if patient unable to undergo MRI, in some of our patient may, that there may be some financial problem. Is there any other option in your hand to assess the diplopia in your clinic? Because those are emergency patients. So in such case, to assess the diplopia, what are the methods in your clinics?
We can do a Hess charting, sir.
Hess charting in all institutes may be available, may not be available. In emergency room, it may not be available. Is there any other tool to identify diplopia?
Word for dot test.
Yeah, word for dot is gross, generally prism bar. This is the ideal in a clinic we should do.
Yes, yes, sir. Prism bar test.
Can we move to the next candidate, please, sir?
Thank you, sir. Thank you. Thank you very much.
Thank you.
Dr. Walda.
Good afternoon. Am I audible?
Yeah.
Okay. Good afternoon, dear doctors, all panelists, and all participants. Thank you for this opportunity. Let me introduce myself. My name is Valda Garcia from Indonesia. Today, I will present.
From which country?
Hello?
From which institution are you working with?
I'm an internship in eye hospital, Siloam Hospital.
In which
Eye
city?
department in Jakarta.
Okay, welcome.
Okay. Would you mind playing the video, please? Okay, the patient was a 58 years old man who had a history of fall from 3 meters height while working. He fell in pronation position and hit a wood block on the right eye. And before being operated, the patient got a head CT scan examination. There was no fracture in orbital base, but there was a septal deviation. And then there was no neurological deficit. In operating room, we clean up the wound. The laceration had irrigated. The hard cloth softened with aqueous, and then the cloth being separated carefully using forceps and scissors. And then the patient got methylprednisolone 125 milligram 4 times daily within 3 days, because through the physical examination, we found RAPD, relative aberrant pupillary defect, and suspected had a traumatic optic neuropathy. And then the hemorrhage being controlled using culture, and then the tissue being detached one by one so that we can identify it layer by layer. And it helped us to visualize there was an embedded corpus alleenum or not. After clean up the wound, we found detached supraorbital nerve with exposed os frontal. We can see here the exposed bone over there was os frontal. That was the supraorbital nerve that detached, and then the tissue being sutured layer by layer. The first, musculus orbicularis being sutured with Vicryl 6.0 in simple interrupted method, and then the adnexal sutured with Vicryl 6.0 with subcuticular or continuous method, and then the skin to skin being sutured with Prolan 6.0 in simple interrupted method. And then after sutured the wound, we re-examine the anterior segment of the eye. Through anterior segment examination in operating room, there was no rupture, there was no corneal abrasion, no corneal udem. There was chemosis on conjunctiva. After the surgery, the patient came back to the hospital. 1 week after surgery, through physical examination, showed traumatic ptosis with hypertrophy. And then 2 weeks after that, there was no symptoms, the visual acuity getting better, and there was still ptosis. And then the last visit of the patient was 3 months after surgery. The best corrective visual acuity showed 1.0, no double vision, the eye movement was free, and the eyebrows were symmetrical. There was a little bit of numbness on superior and inferior palpebra. That is my presentation about my adnexal trauma case. Thank you very much.
Grover, sir.
Thank you, Dr. Walda. I think that was very nicely managed. What would you like to stress most in adnexal injury management, eyelid and eyebrow management? What are the most important things that you consider when doing a repair?
I think the most important is we have to visual the tissue clearly. Like I said before, you have to know what tissue you see. Is there any corpus alleenum or not? Because that is the key, so that we can suture rightly, and then the result of the wound will be get the best result.
Yeah, I think as you stressed during your video, it is good to do a very good wash of the wound and use betadine, because infection and contamination are two of the major sources of long-term problems, scarring, etc. And then what you stressed again was multi-layered closure, so that you don't leave behind any dead spaces for blood or for accumulation of secretions, which would lead to poor apposition and poor wounds. And what is most often a deformity is because the suturing has not been made according to the exact positioning. So eyebrow can be used in a case like this as the landmark, just as we do in limbus, and do a very good apposition of the upper line of the brow with the upper line of the brow on the other side, to ensure that you have done a very good apposition into the right position. So those are the important issues in management in a case like this. Of course, if there is a nerve injury, then it will take its own time for recovery, just as you had a supraorbital injury. If there's a division, it will take much longer. If it's just a concussive effect on the nerve, it would recover much faster. You also mentioned the afferent defect that this patient had. So what was the visual acuity and how much did you have ultimately?
At the first time, the patient had a loss of consciousness. After we gave the methylprednisolone, the consciousness being gained, and then we examined through bedside. Visual acuity was 3/60.
So there was a partial loss of optic nerve function. When do you suspect an injury to the levator muscle? Did you have some residual ptosis postoperatively?
Sorry?
What serves as a landmark to tell you that there has possibly been an injury to the levator muscle as well in adnexal trauma?
Sorry, would you mind?
How do you diagnose the injury to the levator muscle as well in an adnexal trauma? What landmarks helps you in identifying it and tackling it?
Is there any muscle trauma or not in this case?
Yeah, levator muscle. Yes. Levator palpebrae superioris.
We examine the movement of the eye, and then we also examine the reflex of the pupil.
Okay. So if you have a prolapse of the preaponeurotic pad of fat, then you must look for injury to the levator palpebrae superioris and take care of that, particularly to avoid postoperative ptosis. And of course, edema takes 6 to 12 weeks to disappear, when you can finally assess what the extent of residual effect on ptosis is. Thank you. Thank you for a nice presentation.
Yeah, thank you very much.
Thank you very much.
Can we go ahead with the next presentation, please? We are running short of time, sir. Can we start now the postage segment videos? Dr. Mohan and Dr. Rajiv both are there. Dr. Prashant is not available because he has some emergency work. So we can start with Dr. Giriraj Vibhuti.
Take one person, any retina person from the this persons who are present here. So you can take.
Mehul will be there. We can start it.
Yeah, Dr. Giriraj, please.
Yes, sir, I'm ready. Should I share the video? Yes, sir. Okay. I'm Dr. Giriraj. I have done my PG from Shroff Center, Delhi. Now I'm fellow in Joshi Eye Institute, Hooghly. And thank you to the organizers and my teachers. Can we start the video? I'm presenting story of a 35-year-old laborer who presented to us after a blast injury at his workplace. As you can see, corneal tear repair was done primarily, and 1 week later, we took up the vitreoretinal surgery. As we all can see, the vitreous cavity is filled with vitreous hemorrhage. Part of it is altered and part of it is red in color. So it is difficult to make out the anatomy. And we are dissecting carefully, trying not to involve the retina. The B-scan was suggestive of retinal detachment also, so we had to be extra careful. Multiple attempts to induce PVD were done, but we were unsuccessful.
Hi, Sai.
So finally, we tried creating an opening in the posterior hyaloid.
Shakin Singh is not able to get it. Okay, he has sent me message that I am not able to get it.
As soon as we could see the retina through the opening in the posterior hyaloid, we had time to take a sigh of relief, and now we could see the superior retinal detachment with hole also. when the PFCL was injected, we could see multiple foreign bodies inside the vitreous cavity. Even though X-ray showed us presence of foreign body, we were not expecting these many. So the corneoscleral wound was made because of the shape and size of the foreign body. We were not able to grasp it with the regular intraocular forceps. So we used this claw forceps, and we could hold and grasp the stone particle carefully and bring it out via the limbal wound. So one by one, we took out the multiple foreign bodies. This is the second one, then the third one. Fourth one, and finally the fifth one. So that's why the name of the video, 5 in 1. So once we were done with the foreign bodies, still the retinal detachment part was pending. So we had to deal with that. The wounds were sutured. Now, with the use of iris hooks, we did peripheral indented vitrectomy. Base shaving was done. The retinal break was lasered, and fluid exchange and silicone oil tamponade was given. Luckily, macula was not damaged badly in this patient, and central part of cornea was clear. So post-operatively, he could get vision up to 636. Thank you. Thank you to my teachers. Thank you for the opportunity.
Can I make a comment? Giriraj, it was really a brilliant video. It was a fantastic, very rare to see 5 foreign bodies in the same eye, and they've done it so well. And what was the nature of the injury, and whether the lensectomy was done in the beginning or?
Yes, sir. It was done in the primary setup while corneal care. It was a blast injury, sir. He was a construction worker. They were blasting to dig the ground.
Yeah. I just want to know, is there any modality? Of course, you did the CT scan to find out what is the nature of the foreign body. We can find out to a certain extent, but how many foreign bodies are there? Because you found only 2 foreign bodies pre-operatively, and there are 5. You took it by surprise. So it took you by surprise. So is there any way of finding out how many foreign bodies, especially in a blast injury, there can be multiple foreign bodies like this?
Sir, CT scan with smaller cuts we can try, sir, and deep scan.
Okay. Rajiv, there? Where is Rajiv? Mehul, any comments on this?
I think in blast injury, there can be foreign bodies, but they are always visible on the CT scan. But only thing is, we may not be in a position to identify which part of the vitreous cavity, whether it is perforated the sclera or not, that we are never sure. So, other than this imaging, I don't think there is any other technique by which we can pick up these foreign bodies.
I think overall is really a fantastic video. What happened to Rajiv Raman? I thought his comments were...
He was there, no?
Yeah, I saw him. Rajiv Raman? Okay. What are the post-operative visual acuity, Giriraj?
Post 2 months post surgery, he could improve his BCVA was 6 by 36 parts, sir.
With a aphakic correction, of course.
Yes, with aphakic correction.
Are you planning a secondary implant for him, that patient?
He lost to follow up because of lockdown. We have not seen him since last 6 months, but when he comes back, then we will assess and do it.
Dr. Shah, tell him that he should connect. His session is going on. Yeah. 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 Rajiv will be joining. Okay, Mohan, can we call the second?
Yeah, we go on to the second one.
Yeah. Dr. Anshul Goel. Dr. Anshul Goel, please.
Yes, sir, I'm here.
Sai, can you share the video?
Can you please share the audio also?
Just give an introduction about yourself, Anshul.
Hello everyone. Myself Anshul Goyal. I've been trained from Shankar Netralaya, Chennai in vitreoretinal surgeries, and I'm presenting this case. We can start this.
Yeah.
So this patient, he came to us. He said that something hit his eye. He couldn't while he was walking across a construction site, and so there was this foreign body. It was a glass foreign body. Earlier we thought that it looked like a dislocated or a subluxated IOL, and the size of the foreign body we could not determine. So this is the first look inside, and we saw that there is inferior detachment. So here what we are doing is, with the light pipe, I am identifying the exact plane. We don't want any corneal tissue to be there. This is, yeah, so to be there between the foreign body and the incision that we are making to remove the foreign body, because the limbus architecture is all broken by the primary repair, and the grasp was very flimsy. I think I have a poor internet connection, and as you can see, okay, so I'm holding it with my left hand, and I'm scared because it's very slippery. So I just lost my heartbeat there when I actually lost grasp of the foreign body, because I'm enlarging with the right hand and holding it with the left. So I decide to have a firmer grasp, but that is all I can get. So this time I decide I'm not going to leave it, and now I'm cutting with the left side also with my right hand only, because I'm not ready to leave it. And I keep on enlarging. I have no idea of the size of the foreign body. Imaging was not helping because it was a glass or a plastic foreign body. And we keep enlarging, keep enlarging. Finally, I'm sure that it's not going to slip. It is that big. And this is the size of the foreign body. This is a huge foreign body. And then the entire wound that was created to remove this foreign body was sutured, and this suturing took about 1.5 hours, following which there was a very dense capsule, adherent capsule. There was 3 months of gap between the primary and the secondary surgery because of the lockdown, and bimanual surgery was done to dissect this thick capsule that had grown around the entire glass, and then eventually to settle the retina, the vitreoretinal part was done. Cryo was done to the horns of the relaxing retinectomy. Oil was put, and the case was closed. I submitted this video. After that, the patient has had 3 resurgeries, and now he finally has an attached retina and has some vision. Thank you for watching. It was a 16 foreign body.
Beautiful, Anshul. I think you managed it so well. But what basically I do for glass foreign bodies, I have something like a Clayman forceps. I don't know whether you have seen it. This Clayman forceps, which holds especially for iris claw lenses, we use it. Okay, this Clayman forceps can go inside and grasp the foreign body, right? So you'll not be able to see, because the way you are holding the foreign body with the Pierce Hoskins forceps, if I'm right, whatever I could see on the video, because that is definitely likely to slip, especially the glass foreign body of such a magnitude, such a big size. Something like a Clayman forceps which can go inside and hold the entire, because you do not know, but the foreign body is little larger size. That for something for sure. So you Clayman forceps, you go inside and hold, just like the crocodile holding the leg. Similar to that, the Clayman forceps holds so that you will not be able to the foreign body doesn't slip. This is something which you can. By the way, it's a beautiful video.
Thank you, sir.
It was a beautiful video. I think you have done nicely this case, and a really good video.
Thank you, sir.
Dr. Rajiv Raman is there now.
Yeah, I lost the net. Just now got connected again. I missed the video.
Okay, fine.
Welcome back.
Rajiv, good
Hi,
evening.
sir.
Really missed you, Rajiv.
Yes, I missed the video. This video.
Welcome, Rajiv.
Yes, sir. I was there. I heard Rupesh talk, and then my net totally went off. Now only I could again reconnect.
Good. Okay.
Okay. Can we go to next? Dr. Rohini Grover.
Yes, sir. Good evening, sir.
Good evening.
I'm Dr. Rohini. I have done my FNB from Sir Gangaram Hospital, currently working in CL Gupta Eye Institute, Muradabad, Uttar Pradesh. Thank you. You can start the video.
Just a minute, madam. I'm playing it.
Okay. Well, it's not just about. So this video is about a long journey of a foreign body patient. A 20-year-old gentleman presented in our OPD with right eye injury. On examination, there was full thickness corneal wound and fundus showed vitreous hemorrhage, disc edema, macular edema, a rod-like foreign body, and retina was attached. On a X-ray, there was a linear foreign body, radio opaque, and it was a single foreign body. After 48 hours, the surgery was planned. A single corneal suture was first passed in the same sitting, and followed by 23-gauge pars plana vitrectomy. A metal foreign body was seen, and following the core vitrectomy, vitreous around the foreign body was also removed. Seeing the foreign body very close to the macula, a PFCL bubble was put so that the macula is safeguarded. After that, a tricot assisted PVD was induced. Then, using an MVR blade, the supratemporal sclerotomy was enlarged, and using a rare earth metal magnet, the foreign body was retrieved longitudinally as it was linear, so it was retrieved longitudinally, and suture was placed. After that, PFCL was removed, and periphery was looked for any breaks, and inferiorly we found few small breaks. So air fluid exchange was done, laser was done, and silicone oil was put. Post-operative size was measured, it was around 5 mm. First post-op day, there was disc edema, macular edema at the site of impingement. So we started on high-dose oral steroids along with antibiotics. Patient after 1 month came and the vision improved to 20/100, although the OCT showed ellipsoid zone derangement, and the vision dropped again after 3 months because of epiretinal membrane formation. So 2 weeks later, silicone oil removal was done, and the vision improved after silicone oil removal and ILM peeling from 2200 to 2000. But again, 6 months later, there was a complicated cataract, and phacoemulsification and IOL was placed in the bag. The visual acuity again improved. The final visual acuity was 21/25, but there were signs of traumatic optic neuropathy. So this shows the whole journey of a patient of around 11 months. So disc edema and commercial retina can coexist. Retrieval of foreign body has to be planned in MIBS era, and a long-term sequel have to be kept in mind. It is just not when we tell the patient that there is a risk of endophthalmitis and retinal detachment after intraocular foreign body. It's not just enough. We have to mentally prepare them for the future complications and sequel, and keep them on a long-term follow-up. Thank you.
Absolutely wonderful, Rohini. Very nice video. I think very nice take-home messages as well.
Dr. Rohini, very good case and nicely managed. Just one thing, would you use directly the magnet, or you try to use a do a handshake technique? Because many times, being a cylindrical foreign body, and the moment you just try to maneuver it near to the sclerotomy, it will lose and again fall back.
Yeah, actually it fell back, and
Yeah.
that's why the idea of using PFCL was because since this foreign body was in will not float over the PFCL, but any two fluids like BSS and PFCL, they make a interfacial tension, so that helps to deflect the foreign body away from the macula. So did happen that when I used a rare earth
So
magnet,
that's the
it slipped. It
yeah,
slipped.
it is bound to slip. So what you need to do is, once you are in the mid cavity, use a foreign body forceps in the other hand and grasp it, rather than directly using a magnet to track it out of the sclerotomy, because then it is a more controlled. You will not lose the foreign body, because that itself
Agreed.
can cause an impact on the retina.
Agreed.
The changes which you are seeing later on could have been because falling on the fovea itself can cause that. So
Yeah,
I think,
already there was an impingement
yeah,
over the
so
fovea.
yeah, already when you have a compromised state, it would be always better to grasp it with a foreign body forceps with the other hand. Only thing, because it's a negative action and it has got a long sleeve, sometimes you have to be just behind the lens and be careful that you don't touch the lens. But
Yes.
because it will not open,
Yes, sir.
will open only when you go in the mid cavity and then open the thing, and then you can grasp and bring it out. I think otherwise it's a great video. And as you rightly said, that you need to put a bubble of LPFC, it definitely helps. What you would have done if this was not impacted foreign body, it was not impacted
It
on the
was not impacted. It was just impinging over the fovea and adherent to the vitreous, strongly
correct,
adherent to the
correct. So
vitreous.
if you would have found a break there, or if it was impacted foreign body, how your plan would have differed a bit.
We would have displaced it with the help of PFCL only, first of all. And since it was a foveal area, would not have used laser there. Otherwise, if it was away from macula, would have lasered at the break side. In this patient, I would have taken him primarily for ILM peeling there and then under PFCL using BBG staining.
Correct. And no, when you would have done, suppose it is not in the macular area, and when you do the laser.
First, we will have to complete the vitrectomy, then PVD induction. Once the PVD is induced and the posterior hyaloid is free, then we would have picked it up. Many a times while we are picking up those foreign body, they are actually impinging over the choroidal vessels, and they start bleeding. So again, PFCL helps a lot, because if you have put a PFCL bubble prior, this bleeding doesn't take place. The choroidal
Absolutely
bleeding is
correct.
also
Yeah,
controlled.
what you told is absolutely correct, and that also gives you a message. If it's an impacted foreign body, before you remove the foreign body, do a
PFCL has
laser.
to be.
No, do a laser.
Okay.
Laser.
Around
Yeah,
it.
laser under
Yeah, so once
PFC.
you have a bleed, no, even because retina is attached, it is just an impacted foreign body. So before you open up the capsule of the foreign body and try to disengage it, do
Okay.
at least 2-3 rows laser around it
Yeah.
first, because you may not
Yes,
get
sir.
that opportunity
Yes,
once
sir.
there is a heme. So do the laser first and then remove the foreign body. Great case,
Beautiful.
well managed.
Very
Thank
nice.
you, sir.
Thank you, Rohini. I think you've highlighted very well the role of persistence and perseverance and multi-stage procedures, posterior segment. I think that holds true for our adnexal deformities also. I think I've had to do 6 stages for somebody to get a reasonable cosmetic appearance from a cosmetic deformity. I think it's the persistence and perseverance both from the patient and the surgeon that is needed in managing ocular trauma.
Yeah,
Thank
just
you.
one last question to you.
Yes, sir.
You got an X-ray done when you could see the retina very well.
This
Any
was to
specific
know
reason
the
for it?
multiple, because this patient also was working in a factory and had a hammer chisel injury. So we were not very sure that there were multiple foreign body or a single foreign body. And X-ray is a very good tool in knowing and it's economical also
Very
about the multiple foreign bodies.
Yeah, so when
And
the view is not there, you have vitreous hemorrhage and the view of the retina is not
Ultrasound.
that good. That time ultrasound and your
Un-
X-ray is fine. But if you can visualize your retina very well, and you know that there is a single foreign body,
Yes.
so actually you don't need anything, because that takes away the time, the golden time which you have to remove the foreign body. So if
Yes.
you can document it, because recently we had this incidents. The case was delayed for 12 hours because of CT scan and all those things, and he ended up with endophthalmitis in a case where foreign body was seen inside. So
Yes.
even for a medical legal, you want to document it, you can very well take a fundus photograph, correct?
Yeah.
So I think that is again one thing, that if definitely what you said, to look for another foreign body whenever you have one, and if you cannot visualize the posterior segment, you want to do all your modalities. In this case, probably even ultrasound would have sufficed, because it's a small wound. A gentle ultrasound
And
could
gentle.
have picked up. The reason is, see, because your setting, the X-ray is easy to get it done on the same time.
Yes, sir.
Some places where X-ray or CT scan, it may delay the surgery for a couple of hours. It makes a big difference.
True. True. Actually, the primary repair is the priority. So without delaying the primary repair, we should do it first, and then everything else
Great.
later on.
Great.
Yeah. Uh,
I just want to make one comment. Yeah. So Dr. Rohini, excellent video. And just I tell it is X-ray, of course, in some cases, if the patient is not sure about the injury, if primary repair done, as Dr. Rajiv told, we should go for a primary repair. But before vitrectomy, we can, because there may be some causes sometimes. If there is a two foreign body, one foreign body maybe in the orbit. So that X-ray sometimes may helpful.
Yes.
If the patient is not sure about the number of foreign body, that other foreign body may be in the orbit or in next, there may be some medical legal issue in later. So better, but as Dr. Rajiv nicely mentioned, so in case of the open, there should not be any other investigation, but in other cases, to rule out orbital and axial, definitely yes.
Especially in a blast injury, I think it should be important
Yes,
to
sir.
document that.
Yes.
From medical legal point of view, of course, what Rajiv
Yes,
said
sir.
is absolutely right. You can't wait for too long.
yeah. Now, can we call upon Dr. Mohan?
Yes.
Dr. Mohan does not need any introduction. He is available in all webinars full time. Even every Sunday, I think I am seeing him in at least 2-3 webinars. And he is a champion of Premier League. And he had a great presentation.
Thank you, Mehul. And let me, at the outset, thank the Oculotrauma Society of India, President Dr. Mukherjee sir, Secretary Mehul, Dr. Grover, Dr. Purendra, all the other members of the OTSI. As Rupesh Agarwal rightly said, coming to OTSI is always coming back to home. And it's a very, very nice experience. It's a learning experience from the videos. Whatever we have seen today, I think is really fantastic. The topic for today's keynote address is fire crack injuries of the eye. Have a blast, but don't make it your last. So that is going to be the topic of the next 10 minutes. These are my financial interests. I do not know how many people know this Sivagasi. The Sivagasi is a small town in southern Tamil Nadu. Okay, this Sivagasi is very, very prominent as far as the firecracker injuries are concerned, especially Diwali is coming around the corner. And you know, this Sivagasi is a population, it's got about 1 lakh population approximately. But more importantly, this is the firecrack injuries or firecrack workers, the factory capital of the world, I would say. And 70% of the firecrackers in India come from Sivagasi. And they export to so many countries across the world. More than 2.5 lakh people work in the firecrack industry. More than 20 billion turnover. 20 billion is the turnover every year for the Sivagasi firecrack industry, which is significantly very, very large because it's about 280 million US dollars. And Sivagasi is very prominent because of the firecrackers, the matching, the matchbox industry, the printing industry. And why I am talking about Sivagasi is the main component as far as the firecrackers are concerned in this part of the world. Let's see the firecracker injuries. About 2% of the ocular injuries are firecracker injuries. More importantly, 10% of the ocular injuries in children, and most of the injuries reported children is because of the firecrackers, and 14 to 16% of injuries are reported to the bystanders who have nothing to do with the firecrackers. They just stand there, and because of that, they get injured because of the firecracker. This is a very, very important thing which you need to know, because many of them, this is a very significant percentage. Sparklers are constituting for about 19% of the injuries. The flower pots, in our experience, the flower pots, the cone foundation is a very common cause because it bursts. The injuries are caused by the poor quality control of these firecrackers as well, because these firecrackers, which are supposed to light, sometimes burst. Sometimes when they're supposed to burst, sometimes they light. So they do the alternate things, and they do something else, and that is what has taken the what you call the patients by surprise. Bottle rockets going in the wrong direction and blasting in the eye, just like the bomb blast we are talking about in the previous videos as well. Atom bombs and bombs constituting about 37% of the serious ocular injuries. As you know, sparklers produce mainly conjunctival or corneal abrasions. Rockets, cone fountains, and bombs produce serious vision-threatening problems. I think this is something which we have to very, as ophthalmologists, we have got a right, we have got a duty, a responsibility, especially when the people come, especially many children come with the firecracker injuries. Studies have shown that poor quality of the fused lead responsible for majority of these accidents. In combination, firecrackers, the cone fountain thing with uncertainty, the bomb explosion increase as the two separate fused leads, thereby making them extremely dangerous. And that is why there's an uncertainty. You do not know which is going to burst, which is going to light. That is a big problem as far as the firecrackers in India are concerned. There are different types of ocular injuries. Every part of the eye can be involved as far as the firecrackers. We have seen starting from very minor corneal abrasions, ifema, iridodialysis, traumatic cataract, corneal tear, rupture globe, retinal detachment, vitreous hemorrhage, macular hole, and so many other problems, vitreous hemorrhage, macular retinal detachment, open globe injury, ruptured globe, and all these intraocular foreign body because of the blast, because these firecrackers contain also shrapnels which can go inside the eye as well. And this is a very serious problem. It can be a very, mild problem like a subconjunctival hemorrhage like this, or necrosis, or the firecracker injuries just depositing on the surface of the conjunctiva, on the surface of the ocular surface, which just requires a wash. Or it can have a ruptured globe. You can see a ruptured globe in a 15-year-old boy with a cracker injury, and you can see that on the right side, the ruptured globe repair being done, which is a very, very common, not an uncommon problem as far as firecracker injury. This is the most common thing, the corneal tear, the limbus to limbus corneal tear, sometimes extending into the sclera also, almost like a ruptured globe. And these are the corneal tears which were very, very commonly seen. And sometimes, many of the times, what happens is, because the blast occurs right on the eye, the corneal tears are very, very irregular or zigzag. I'll be showing one video as well. This is a 22-year-old man with subconjunctival hemorrhage and ecchymosis following a firecracker injury. There's another guy who's actually had a firecracker injury. You can see that there's a problem in the cornea as well. This is a traumatic cataract. You can see the same guy. Iridodialysis, you can see that. And what I'm trying to do is just a routine thing. You can see that there's a posterior synechiae. I'm trying to go ahead. Always make place when this is the traumatic cataracts and firecracker injuries, there can be a pre-existing PC tear as well. And this we have to think, even if you document by means of B-scan or the ultrasound or the UBM scan as well, is very, very difficult sometimes, many times, to document the PC tear preoperatively. You have to be aware of this problem, especially when this thing. So the patient went ahead and this thing. You can see another 12-year-old boy who had a firecracker injury, a flower pot bursting into the eye, and you can see a rupture of this thing, and flower pot injury is not very, you can see there's a zigzag injury. The zigzag injury, which is very, very common, irregular corneal tear, which involves a lot of work from the corneal surgeon, the trauma surgeon, as Rupesh was rightly telling, unless you have, you see, we are very important that you have make sure the maneuvers in the anterior chamber are very gentle and minimal as well. Not sure, because as a young fellow, you don't want to injure the lens. The lens is fairly clear. You can see that the corneal tear repair is done with all the protocols which have been mentioned by Rupesh Agarwal in his talk, and taking of almost a full thickness cornea end to end, and making sure that you define the limbus, and then going ahead with the zigzag corneal tear repair, which ultimately produced fairly good results in this patient. And because the visual axis is fairly good, and the patient recovered about 6/18 vision. You can see that the zigzag corneal tear repair at the end of the surgery, which is very, very common with the corneal tear, with this rocket blast, it is a bystander. As I told you in the beginning, the bystanders are one of the major problems as far as the firecracker injuries. They just stand there and the firecrackers burst, and they are caught unawares, because these people are watching something else, and that is the reason why the rocket blast is very, very common, because the rocket goes in a wrong direction. You can see that there is a ruptured globe as well. And this is an older patient. You can see the ruptured globe. The entire ocular contents are outside. I'm trying to do something like using a cutter, because the entire vitreous was outside. The entire the ciliary body, the iris was there. I'm trying to close it with the vehicle suture, and all of a sudden I found there was an expulsive hemorrhage as well. I had to close the wound, and that you can see that at the end of the surgery. And these are all things which you have to be in the ruptured globe, very, very common thing which you have to be aware of. You can see that all of a sudden the pressure is going up, and the patient had an expulsive hemorrhage, and we had to absolutely take the patient again for second surgery. Again, the shrapnels can be intralenticular, or it can be in the anterior chamber, it can be the vitreous. You can see another patient had a corneal tear repair, and then I went ahead with the phacoemulsification. You can see that these are small iron particles, because these firecrackers, what they do is sometimes there are some firecrackers, they make it a little heavy, and some, for example, the rockets and the outs and other things, and they fix up the iron to make it a little heavy, and sometimes this can blast into the eye, and this is what has happened. You can see the intralenticular foreign body, which I tried to remove in this particular patient. This is a firecracker injury, a blast 30-year-old female. She was referred to me from Madurai, from Sivagasi. She was actually working in a Sivagasi firecracker industry, and she got caught in the fire which was there. The blast was there in the industry itself, and she was referred immediately because she had 60% or 70% burns all over the body, and she was referred to a Madurai General Hospital. And after 2 weeks, she was referred to me from Madurai, and from Sivagasi, she is referred to Madurai. She was kept in the ICU in the burns ward, and then kept to sent to us. We found that she had a self-sealing corneal tear. You can see that, and also you can see that there is a corneal tear which was there almost after 2 weeks after the surgery. We took up the patient because they ignored the eye, obviously, because the life is more important than the eye. They didn't see the eye at all. You can see there is iridocorneal adhesions which were there, which was released, and gentle removal. It's very, very important. Very, very minimal maneuvering in the anterior chamber, which is again very, very important. And this patient, we have multiple small stab incisions we put. Make sure that you fill up the globe with the viscoelastic, good viscoelastic, and then clean up the this thing and remove all the iris which is attached to the cornea, and then went ahead with the corneal suturing, which is at the end of the surgery. You can see here how this patient did very well. Of course, the patient had posterior segment problems as well. There's another patient, the blast injury, which came. These are patients who come to us after a few months after surgery. For example, this patient came to us after 1 year after he didn't even realize there was this thing, atom bomb injury, and developed a chronic macular hole. The macular hole size was 2,300 microns. There's another patient, young lady, who was referred to me from the Middle East, and you can see here she had a traumatic cataract, zonal dialysis, iridodialysis, and you can see that. And all these problems were very, very common in firecracker injuries, because it impacts just like any other blast injury. And I can see that I did the femto for this particular thing, because I want to make sure that the zonules are taken care. The rexis is very easy, and went ahead and did the CTR and the lens implantation. because the patient had traumatic mydriasis as well. I did a single pass 4 through pupilloplasty, then the iridodialysis repair, and the patient recovered about 6/18 vision because the patient had a traumatic the macular pathology as well because of the firecrackers. Now, how can we prevent these injuries? There are do's and don'ts which I want to give as take-home messages. Burst the crackers in open space. Avoid bursting within the household premises. Adult supervision is mandatory. Always go for the best quality of the crackers. Wear protective footwear. In order to maintain distance, always have a long lighting band. Wear cotton clothes. Don't have loose clothes. Have adequate security measures like water, sand, and fire extinguisher by the side. All these are very, very important. Do not light the fuse by keeping the face above the flower pots. Do not keep the fireworks varieties nearby the display the items. Do not hold on hand during or after lighting, which is very, very commonly done by children because they want to play with the firecrackers. Avoid loose clothes and light the fuse with a long wand. And these are the don'ts, wherein do not wear loose clothes, avoid rockets and atom bombs, do not relight an already lit cracker, do not burst any inflammable articles. And very commonly, what we have seen firecracker injuries because of closed spaces. They have firecrackers inside the house. They burst the firecrackers for want of space. That is a big problem in major cities like Chennai or Bombay or Delhi, and that is a problem. The take-home message is firecracker injuries can be grievous, sight-threatening. Children must burst firecrackers only under adult supervision only. Following the protocols is mandatory while bursting the crackers. Recognition and early treatment is very, very important. Early referral to the ophthalmologist, just like the golden hour, Rajiv was rightly telling, prevention is always better than cure. This is something which I'm working with the government because Sivagasi, as you know, is a major component and major this thing for Tamil Nadu government as well. And I'm working with the government on this. The firecracker can cause serious injury to the eye. This is what a statutory warning, similar to what they are giving for the smoking and alcohol consumption, is injuries to the health, and smoking can cause cancer, and all these statutory warnings similar to that. I also want to bring about this statutory warning, which is also very, very important for the firecrackers, can cause serious injury to the eye, and that is what this is a standard of wherein firecracker injuries can be. These are the advocacy I want to say because Dr. Mukherjee wanted me to sing, which is very, very important in a keynote address like this, wherein statutory warning is very important. License, not only for the firecrackers, but also for the people who are using it, is very, very important. Protective gear, very important, just like the gear we're using while working on while bursting the firecrackers can prevent the injuries to a large extent. Quality control is, I think, something which is very, very dismal in our country. The quality control of the firecrackers, though they have something like NABH or ISO standards for many of the firecrackers, but the quality control, if you go to Sivagasi, I have personally visited Sivagasi, all these factories to do some work on this, but quality control is absolutely deplorable state in this because there's no consistency in the quality. And that is a major problem which is plaguing that entire industry. Allotting open air spaces by the government, creating awareness among the public, which is again very, very important. Messages on the TV during the Diwali time, messages on the mass media, on the radio about firecracker injuries, not only to the eye, but also to the burns in the rest of the body is also very important. Rajan Eye Care family wishes you all a very, very happy and safe Diwali as well. Thank you very much, OTSI. Stay home, stay safe, stay healthy. Thank you very much for the wonderful opportunity and the patient hearing as well.
Thank you, Mohan. It's absolutely appropriate topic just before Diwali.
Yes, sir.
Your all these messages must go to all people, all the person who are interested in preventing these firecracker injuries. To your list, I would like to add one more.
हो सकता है
Can you just mute Purender?
मुश्किल है वो बस यही कारण
So Mohan, you can add only one thing, that sometimes these children, the mischievous condition they do it, what they do, they put a tin or some cover over the bombs, and then when it blasts, this particle of this thing, they go as like splinters, and the damage is more as compared to the normal burning of the cracker.
Yes, sir. Absolutely, sir. I fully agree with you, because these are all, because children playing around with the crackers is something which is really every Diwali time we see. I'm sure, because in Shankar Netralaya also Rajiv will agree with me on this. During Diwali time, despite the fact that we have got so many awareness campaigns going on, but the parents, I feel the parents should be given what do you call a lot of education on this particular thing. Yeah.
This time, actually, again, Delhi High Court had passed the ban on the firecracker.
Yes,
And
sir.
also, last time they have made it partial ban. This time it's a complete ban almost.
Yes,
And
sir.
a similar type of step has been taken in West Bengal and two other states.
Rajasthan and Odisha.
Yeah, Rajasthan and Odisha.
Yes,
Quite right.
banned.
So I think the awareness is gradually spreading, and we'll have to implement more and more these things and give the awareness to the people, so that the firecracker burning is, I do not say stop, it has to be moderated, because stopping you cannot do it. There are a lot of problems with the stoppage. You know that.
Yes, sir.
Because Sivakasi is such a huge industry.
Huge industry, sir.
You just cannot stop it, because there will be financial loss. So many people will lose their jobs.
Yes,
So you
sir.
cannot do all these things. Only thing is that it has to be done. All this firecracker burning must be done under proper supervision. Proper firecrackers are to be manufactured. No underrated firecracker should be there, and no experimental firecracker burning.
Thank you. Thank you, Dr. Mukherjee and Dr. Mohan Rajan. Dr. Mohan, that was a brilliant talk. Very, very useful for us. And there were a couple of points that I wanted to raise. One was that we must strive as a society for the cracker burning to be used only in communities, only in community displays rather than in individual. I think a time has come for that, because it's not just ocular injuries, it is the facial injuries, it is life-threatening. I've seen lives being lost after cracker injuries, and the pollution impact, which is massive and which is responsible for thousands of deaths. And that's the only reason why the courts and why the state governments have banned it. They've not yet spoken about the trauma. They've only been concerned about pollution. Whatever the reason, we welcome that. We must insist on its being used only in community groups where it is done as a display. Number two, I think the pollution aspect of green crackers has been discussed a lot, but their potential for injury and their safety for injury has not yet really been spoken about.
Yeah, quite
I
right.
think we need to insist on that as well. Once the green crackers are being discussed, we need to be talking about the safety aspect of those and the quality control of those. I think that should become an important issue and an important part of our advocacy.
Yeah, actually, it's a double-edged sword, sir, because on one side, we have an industry which is really flourishing, which is actually the pride of our country. If you look at the industry, no other industry will have a turnover of 20 billion rupees, which is it's really one of the top industries, I would say, because probably the Chinese crackers are probably slightly in front of us, but overall, I would say this industry has to be refined and taken up to a different level. That is what we have to think about on one side. On the other side, we have all the problems which is faced with the firecrackers. Now the governments like Rajasthan, Odisha, Delhi and other states have also banned because of pollution. They are not mentioned about the trauma. They are not mentioned about the trauma to the eye, the burns which are occurring in the body, which is life-threatening, the sight-threatening. They are not mentioned about. They are talked about only the pollution which is the firecrackers, especially in this COVID era. They don't want to have the pollution which is going to add fuel to the flame as far as the corona is concerned. So that is the reason why. And the noise pollution, they have brought about many rules, especially in Tamil Nadu, about the timing of the thing. You can't do the firecrackers, you can't burst firecrackers after 10 p.m. You can't burst firecrackers before 6 a.m. in the morning. Between 10 p.m. and 6 a.m., no firecrackers because of noise pollution which it is causing. So that in that way, I think one by one, all the statutory warnings and other licenses, other regulations have to come into place. That is my opinion.
And we'll have to work a lot to bring this for awareness of everyone, all strata of society, all legislators, all judges so that this can be implemented.
Yes, sir. Yes, sir.
I request all the judges and all the people present here that please put up some message before Diwali in your WhatsApp group and also in the Facebook group, so that the this message goes to most of the people.
Absolutely, sir. I think it's a very important point.
Mehul, you are muted. Unmute yourself and.
Dr. Harshvardhan, he will be the next presenter.
Good evening, dear seniors. Excellent talk by Rajan sir. I am Dr. Harshvardhan Ghorpade. I am a cornea, ocular surface and refractive surgeon at the OTSI Institute in Fortis Hospital, Navi Mumbai. And I'll just give a short introduction of this case because the slides move a little faster. So this case is a classic example of a multidisciplinary and multi-level approach to get maximal outcome from a hopeless situation. So here the man presented in the middle of the night after getting involved in an armed fight with mutton choppers, and he had his face and eye literally cut into half. And he did not recognize light initially when we saw him, and we decided to do the primary repair in the middle of the night, including the repair of the face. And then later on, a couple of months later, with the corneal scar and vitreous hemorrhage, we got rid of the vitreous hemorrhage with vitrectomy and peripheral laser. And at the same time, we placed a sulcus fixated lens. And we hoped that he could get better vision. He did improve a lot, but again, he had a lot of photophobia. So in the third stage, we went ahead with the replacement of the cornea and putting in an anti-radial lens. While in the fourth stage, it was rehabilitation in the form of suture adjustment and RGP lenses. So from no PL, he went to 6x6. So this is this journey of almost a year and a half of this young man of 25 years old. Sai, please play the video. So presenting a case of mutton chopper injury, a 25-year-old male presented with mutton chopper, sclera to sclera deep tear up to the equator and involving the face. This was his presentation. We performed a primary repair with cornea and face suturing. He had iridodialysis with vitreous hemorrhage and a corneal scar with photophobia. So we performed a vitrectomy and placed a sulcus fixated lens. But because of his photophobia and the scar, we had to do a third stage surgery almost a year later with PK and IOL exchange with anti-radial lens. His vision improved to 6/9, and he was very happy. But we still did the fourth stage of rehabilitation with suture adjustments and RGP lenses to give him 6/6, and he's back to his job. So this is the video of the last stage where we removed the old lens and did a vitrectomy, placed an irradial lens and did a corneal transplant in the same sitting. Luckily, in all this entire journey, his IOP was well controlled, and we did realize that there has to be something. And then there was a small ciliary body, probably detachment in the periphery, which was giving his IOP control. And this is his result at the end of the third, with clear cornea, no glaucoma, no vitreous hemorrhage, and no photophobia. So meticulous management at the right stage will give us great vision in these hopeless cases, and we should never give up in these cases. That's the message I want to convey. Thank you so much for a patient listening.
Absolutely brilliant, Ashwardhan.
Thank you, sir. Thank you, sir.
Fantastic. I just want to know why you didn't, why you could have just left the patient a phakic in the first one. Because when you have a corneal tear and you want a deformed anterior segment, I don't want to put a lens because you cannot calculate the power of the IOL. It's very difficult to do a thing. You could have just left the patient a phakic in the first, and then take care of the other problems which are there, and then probably so instead of doing an IOL exchange and doing the aniridia lens as well. Of course.
Well, yeah. Sorry. So the idea was that so the patient was young. He was ametropic to start off. We had a good idea of his axial length. We had a good idea of the IOL power from the other eye. And we could see the peripheral rim of the lens bag. So although the lens was out and the iris was out in the initial stage, in the first when he presented, but we could still have a chance of placing the lens, and it is always better to give him vision without contact lenses and other things. That was the idea. So we thought that with the scar and with clearing of the vitreous hemorrhage, he should improve, and he should be happy with that. But his expectations went on increasing after that. He came again after 3 months, said, can you get it something better than this? I'm ready for a transplant, and I'm having a lot of photophobia. I'm not happy with I have to close my eyes every time. So when there is bright light. So then that motivation came to go for a transplant. And then we were thinking about an artificial iris and those kind of things, but the anterior chamber was crowded and we didn't want to end up with unnecessary glaucoma issues. So we decided to replace the lens, and an irradial lens went well with him. And luckily he's doing very well now. He's into his job and back to his work. Thank you.
What is the final visual acuity you said?
With the RGP lens and the corrections that we gave him, he's 6/6, but he doesn't wear his lenses. He's happy with 6/9 actually.
Great case. Dr. Harshvardhan, very good. Just one question. He had vitreous hemorrhage when you started with.
Yes, sir.
What was the time when you opted for a vitrectomy? It was a couple of months later?
Yes, sir. We wanted the corneal edema to settle for the retinal surgeon to get a good view. We also wanted to examine the periphery as much as possible to look for tears or anything. And that is why we waited about 6 to 8 weeks for the whole thing to settle, inflammation to go down, to attempt, because we were also worried about going into hypotony, phthisis. Instead, if we do too many interventions at a very small gap. So that was the idea.
Sure. See, that's a good approach, and luckily nothing happened. But when you have a vitreous hemorrhage, traumatic vitreous hemorrhage, and you are not able to visualize the peripheral retina, it's a good idea. It's a good idea to go early, because many times they have a detachment, and once they have detachment, you will never get this 6/6 vision which you got it. So
Absolutely.
I think if I were in your position, probably that stage when you are not able to visualize and you are doing the surgery, unlike diabetic vitreous hemorrhage where you can wait for 2-3 months for it to clear, traumatic hemorrhage, if you are not seeing the periphery, better to go ahead with it.
Yeah, the idea was not for the vitreous hemorrhage to clear on its own. The idea was the corneal edema to go down, because the cornea was too battered, and the retinal surgeon didn't have any view actually. He was just basing his diagnosis on B scan and those kind of things. So that is the whole thing. I agree. We should do it early, but I mean 6 to 6 weeks I think is not very long. I mean, you can take that chance in already a hopeless situation. We had already warned the patient that we may not get anything.
I think 2 weeks will be optimum time.
Yeah, actually, I would not even go for 2 weeks in this situation if corneal view is not there. Edema, if it is only edema, because you anyway landed up with a PK at a later stage.
Yes.
So we would have intervened a bit early along with PK at this stage, because see, I have seen cases where people have just minimum vitreous hemorrhage, but periphery could not be seen and they delayed it. They said to 3 weeks, 4 weeks, we will do the vitrectomy. By the time he came with a RD, and with blood inside, it's a perfect material for a severe PVR, and they'll end up with closed funnel RD. So I think here the essence is that you should intervene early, and I think you did pretty good job as far as we could see the initial picture. The extent of injury really managed pretty well.
Yeah, I mean, I'm a anterior segment surgeon, so I was mostly relying on my retinal surgeon for this, and he was also of the view that we should do it early, but we were just trying to see if it clears up a little bit, some idea we get what we are doing, unnecessarily catching up the retina while doing vitrectomy should not be a problem. So that's the whole thing. Thank you, sir.
Just want to know, Rajiv, how frequently we do a B scan for these patients when you have vitreous hemorrhage, traumatic, and you want to visualize the periphery to a certain extent, at least. How frequently you do the B scans?
B scan you need to do initially, and probably if you are not planning a surgery, definitely treat it every week. Every week you treat it. Yeah, every week you see for what is the status of retina, and you want to go early as early as possible.
Absolutely. I think that's a good message.
Yes.
Especially in a traumatic vitreous hemorrhage, you don't want to wait for too long.
Yeah. Next candidate, Dr. Hina Patel.
Thank you, sir. Thank you.
Audible? Am I audible?
Yeah, yeah.
Yes. Good evening, respected judges and dear participants. My name Dr. Hina Patel. I am second year DNB ophthalmology resident from Dashti Netralaya, Dahod. And my topic is role of anterior chamber maintainer in ocular trauma. Please mute the voice of the video. In the first case, there is a wooden stick injury leading to the retrocorneal membrane formation. AC maintainer is used to reform anterior chamber by placing it at the limbus, which irrigates the anterior chamber with the balanced salt solution and helps to direct the fluid current from anterior to the posterior, which is helping to keep the vitreous back. With the collapsed AC, it is difficult to remove the pigment residues and lens material from the anterior chamber. In the second case, there is injury by the iron wire leading to the corneal tear. It is difficult to close open wound when anterior chamber is collapsed. Collapsed anterior chamber can lead to endothelial cell damage while suturing the cornea, and thus anterior chamber maintainer helps in preventing corneal edema. Full thickness corneal tear extending from 7 to 10 o'clock can easily be sutured in this case in the help of presence of anterior chamber maintainer. In the third case, there is injury by projectile iron nail leading to traumatic endophthalmitis in a 36-year-old male. Management of traumatic endophthalmitis, which occurred due to the iron nail in his right eye, can easily be managed with the presence of anterior chamber maintainer. In the fourth case, there is injury by thorn of tree leading to traumatic cataract. The intraocular maneuvers in the management of traumatic cataract occurs entirely in the anterior chamber. So, it is essential to maintain the anterior chamber depth throughout the procedure. Shallow anterior chamber depth can be detrimental to the iris tissue, posterior capsule, and the capsular bag, which can increase the incidence of intraoperative complications like secondary bleeding and vitreous prolapse. In the fifth case, there is blunt trauma by the stone leading to the traumatic nucleus drop. Improving the anterior chamber depth helps in managing traumatic nucleus drop by preventing destabilization of the vitreous body, decreases the risk of PVD, peripheral retinal breaks, and retinal detachment. Anterior chamber maintainer prevents intraoperative and postoperative complications, reduces ocular morbidity, and improves postoperative visual outcome. Thank you, OTSI.
Really wonderful concept. Very simple, but very elegant, I would say. Because we use anterior chamber maintainer for almost everything, but now we have opened up a new vista. Really, hats off to you. Is a very nice concept. Because the anterior chamber maintainer, as you rightly said, whenever you are in trouble during phacoemulsification, when you have a PC tear, put an anterior chamber maintainer, because that tampons the break and also prevents the hydration of the vitreous. Okay, that is very important. Again, having an anterior chamber maintainer while doing a corneal tear repair, I think we should start doing that as well, because that will maintain the anterior chamber to a certain extent, and that will actually facilitate your corneal tear repair much better. Lovely concept. We also use the trocar anterior chamber maintainer, which has been devised by Amar Agarwal. I don't know if you have a chance, you should use it. It's just like a trocar and cannula. You put it in the vitreous cavity, similar to the trocar anterior chamber maintainer is something which you start from the posterior limbus, screw it up and enter the anterior chamber. It's a watertight incision. because other anterior chamber maintenance you do not know, because you can put a bigger incision, sometimes you put a smaller incision. If you put a smaller incision, sometimes you can produce a dismissed detachment. If you put a bigger incision, that can be leaked from the sides of the from the incision as well. I think this is a very, very important. I also devised another anterior chamber maintainer which is available to Appasamy, which is called the needle anterior chamber maintainer, which is a 22 gauge needle, which is just uh, pierce the cornea straight away, and it produces on the sides. It can produce, the flow comes from the sides of the needle, so that it is easier for you to maintain the anterior chamber. So that is, I think it's a very nice concept, very simple concept, well-known concept, but you have used it for so many other conditions, which is making life easy for us. Hats off.
Thank you, sir.
Good presentation. Just one point, that in many of these cases you showed had a vitreoretinal surgery. And I think the message should go very clearly. If you're not able to visualize your infusion cannula, better to use a AC maintainer to start with. I think that is very important message. However, I would suggest that once you clear up the media and you are able to see your infusion, change to the infusion again. That is important. Don't complete your full VR surgery with this many times, because you don't have that liberty of IOP control with the AC maintainer. When you are going inside, sometimes you would like to have a increase your IOP. So once you are able to visualize your cannula, switch back to your infusion, and don't be hesitant in using a 6mm cannula in these cases. 23 gauge, that should suffice. But I think keep that in mind. But definitely, when you are not seeing, especially in your some of the cases which you showed, definitely your cannula will not be seen. It's better to put a AC maintainer and start your surgery.
Can we move ahead, sir?
Wonderful, wonderful. Very nice.
Sir, Dr. Mahato.
Yeah, last. This is the last one. Mehul.
Yeah.
This is the last one.
Yeah, this is the last one.
Vishendu. Yeah.
Good evening, respected teacher. Am I audible?
Yes.
Yes, sir.
Good evening, respected teachers and dear colleagues. I am Dr. Shishandu Mahato. I completed my MS from RIO Kolkata. Now I am doing my VR fellowship in BBI Foundation Kolkata. So today I am going to present a challenging case of long-standing intraretinal foreign body. Please start the video. So to start with, this is a 36-year gentleman who presented in our OPD with a dimness of vision in the left eye. He had a history of trauma in the left eye that was 10 years back. Examination, we could find a hole in the iris in the left eye, and on the fundus examination, we could see a foreign body in the retina. ESG was suggestive of metallic foreign body, and ERG showed negative B waves, which was suggestive of siderosis. Now the video, we strained the vitreous with triamcinolone. The PVD was induced, and now we are doing the complete vitrectomy. We can see the foreign body rested just superior temporal to the disc. Before starting, we did the thorough laser around the foreign body. Now with the MVR forceps, we are trying to dislodge the foreign body from the side as it was encapsulated. But at this stage, it suddenly started bleeding profusely. The bleeding was so profuse that we tried to do the cautery over the area, but the site of bleeding exactly could not be located. We tried various methods by doing FG, by increasing pressure, giving LPFC over the area, but it was not going to be stopped. So we tried it for around 30 minutes. After a good struggle of around 30 minutes, we could achieve some sort of control over the bleeding. Now we can see the foreign body is impacted in the retina. As the iron content was expected to be low in the foreign body, so we grasp it with a forceps for the removal. We not tried to any metal. So now we are taking the foreign body out through the sclerotomy port. After that, we check the retina and it was found to be attached. We're doing the FG and the retina found to be settled throughout. After doing FG, we are now injecting the silicon oil inside the vitreous cavity for tamponade and exchanging the air with the silicon oil. Now we are closing the ports with a suture and as well as cautery. On post-op picture, you can see the retina is well attached with a scar near the macula. So to conclude, it is really challenging to remove a long-standing intraretinal foreign body we should not lose our patience in this scenario, because patience is the key of success in these difficult situations. Thank you, sir.
Very nice video, Shishan. Very nice video. Why did you do a laser before you removed the foreign body?
Yes, sir. We did the laser around the foreign body, 360 degree, well lasered.
Okay, you didn't.
That was not shown, sir.
Yeah, you didn't
Actually,
mention
that was
it.
missed.
That's
Yeah.
not shown. That's
Yes,
why.
sir.
Yeah. Yeah.
Actually, it was encapsulated, so everything was looking white, like the laser marks as well as the capsule.
Rajiv?
Great case, great, nicely managed, though the video quality was not very good, but we could appreciate whatever you have done there. I would say if you were trying, because many times, no, posterior pole, if you have this foreign body which is impacted and capsule and there is a bleeding and you cannot find the foreign body, what will you do? It is not coming out now. You tried making a capsule, opening in the capsule. It's deeply embedded. We could understand that it is deeply embedded because there was a bleed. And so in these cases, what should be done?
Sir, we can try with the soft tip cannula to dislodge the bleeding, the clot as much as possible. That will be the most.
Yeah, many times, no, you try removing and you don't see, you open that capsule. If it is anteriorly located, you can try from outside.
Yes, sir.
Like a buccal, localize it and try to make a scleral cut down. You can still remove the foreign body. But the place where you are having your foreign body was posterior pole.
Yes, sir.
You don't want to make a large opening there. Sometimes there, even we have a case where the silicone oil injected has gone into the orbit. Okay, because of that large opening which you created. So sometimes in these cases, just leave it. If you went to the extent that you tried opening the capsule, it is, and still you cannot find that foreign body, better in that case, better to close it rather than removing and creating a large defect there. That means it has really penetrated the sclera too, and pre-op imaging definitely helps in these
Yes, sir.
cases.
USG was suggestive, but it was just in the retina, not piercing the sclera. The USG was suggestive like that. Thank you, sir.
Thank you.
How do you manage the bleeding? Suppose the bleeding, sometimes when you remove the foreign body, there can be severe bleeding from the choroid as well. How do you manage?
There are few steps, like we can do FG and increase the pressure to 60 mm of mercury and wait for some time, but not long, because that will compromise the optic nerve perfusion to some extent. We can put LPFC over there and wait for some time for tamponade. We can do direct compression. And if we can see the bladder, we can do cautery direct.
Yeah.
Good.
Many times, even if you have a foreign body there, you know that anyway it is impacted on the retina. You can even do a little blind cautery around it.
Yes.
Because you know that is anyway a dead retina and there is something bleeding from there. It's a choroid which has bled from there. So if none of your measures worked, as you rightly said that you tried all of them, you can even do a cautery around it.
Before removing the foreign body. Before removal.
Yes.
Yes, sir.
Very nice. Very nice. Good.
Thank you, sir.
Fantastic.
Yeah. Dr. Mukherjee, sir, can you announce the result?
I don't have the seat. You announce the result.
I'll send you.
Okay. Meanwhile, I'll just announce that our next symposium will be in the December, and that will be in the chemical injury. In the December, the date is not yet fixed because of the foreign faculty, they have not confirmed, but it will be on chemical injury. Yes,
We are ready with the entry segment result.
Yes, you announce, no problem.
Okay. For entry segment, I think the maximum mark achieved by Dr. Rashmi Krishnamurthy.
What is Rashmi Krishnamurthy?
Thank you, sir. Thanks a lot.
And the runner-up is Dr. Anita. Is she there?
Where is she?
I'm there, sir. Thank you.
So first place, the winner will be getting the 10,000 rupees gift voucher, and the runner up will get 5,000 rupees gift voucher.
Great.
Along with an
Thanks a
invitation
lot for the
to
opportunity.
Along with the invitation to attend the physical conference of OTSI when it happens. Winner and the
Thank you.
runners-up.
Thank you, sir.
To be in contact with Mehul sir for this, our General Secretary.
congratulations, both of you. Brilliant presentation.
Very nice.
Thank
Congrats.
you.
What about posterior segment?
Posterior segment, the result is out. The winner is Dr. Anshul Goel.
What is Anshul?
And the runner-up is Dr. Hina Patel.
Very good.
Is there not?
Yeah.
Thank you,
The
sir.
runner-up is Dr. Hina Patel.
Thank you.
Congratulations to both the winners.
Thank
Great
you.
work.
Thank you for
I
the
have a
opportunity.
request, please put on your video and come to the screen. We are going to take a screenshot of everybody, all the participants and all the panelists, judges and everybody. Please come on to the screen.
Thanks, Anshul, for sharing the video. I had a chance to look at his video through the drive. So he shared his video and I could see the video also. That's good.
I'm glad you liked it, sir.
But what we should say is, though there are winners and runners-up, but majority of videos were of very good quality, and they had originality in the videos.
And Mehul, we decided that
They were all neck to neck, in my opinion.
all the participants will get the certificate from OTSI, all the 12 participants.
Thank you.
I think we must appreciate the overall quality, which was brilliant.
Very good,
And
very good.
the entire spectrum was represented, from adnexa to ocular muscles to anterior segment to posterior segment. I think that was a very educative session in that way. And with two stalwarts giving their keynote addresses on
Great.
important topics. A great session. Thanks, Dr. Mukherjee and Mehul, for organizing.
Thank you very much.
Very nice.
Thank you, Mohan. Thank you, Rajiv.
Thank you all, Mohan.
Thank you.
It was so challenging and difficult
Thank
to.
all the executive members, all the
Thank you,
executive
Rajiv.
members who are behind us.
Thank you.
Thank you very much.
Evaluation was very difficult because all the videos were of good quality and all were very meticulously presented, and in such a short time of 3 minutes they have done a great job. I really appreciate. It was definitely
we had real problem in sorting out
right.
Out of 53 to sort out all these 12 videos. All were good and with original things.
Correct.
No doubt, sir.
Undoubtedly.
Fantastic. It was difficult. They were all close neck to neck, in my opinion.
All were good.
All were fantastic.
All were good. And we had a good international participation also in the videos.
All were original videos. And number two, some innovations were there in the video.
Very nicely done, Dr. Mehul. I appreciate your efforts behind this. And I appreciate Dr. Mukherjee's efforts too in bringing this 25th Silver Jubilee year of the OTSI. Very nice. Thank you all.
Thank you.
See you next time.
Thank you, Rajiv.
Bye-bye.
Chemical injuries.
Mehul, Mukherjee sir, Grover.
Yeah. Thank you, Mohan. Thank you. And please remember, all the people must send some message before Diwali for the firecrackers to all the.
I'm going to send firecrackers to everybody.
Yeah. You have already done it.
And all the participants, firecrackers, one packet will come to you.
Dr. Mohan,
Safe firecracker.
the electronic firecracker.
Okay,
Happy Diwali to all. Happy Diwali.
Happy Diwali, everyone.
Happy Diwali, everyone. Happy Diwali.
Happy
Have a safe
Diwali.
Diwali.
Thank you, everybody. Happy Diwali.
We enjoyed your presence, everybody's presence.
Thank you, sir. Thank you all.
Happy Diwali
Thank you.
and thank you,
Thank you.
everyone.